Dinesh, can we start?
Good evening, ladies and gentlemen. The Indian Academy of Otolaryngology and Head and Neck Surgery (IAOHNS) has been
Recording in progress.
organizing the GSK IAOHNS webinar series. This is the 11th episode, and this time contemporary ENT practice. And this month we have chosen the interesting topic of current scenario on seasonal flu and COVID. We have Dr. Neha Mishra, who is the infectious disease consultant from Manipal Hospitals, Bengaluru. She'll be delivering a talk on viral respiratory tract infections, relevance in COVID era, which will be followed by a panel discussion on the rational management of pediatric Otitis Media by Dr. E.V. Raman from Bengaluru. Probably all of us know that Dr. E.V. Raman is the director of the Children Airway and Airway Center at Manipal Hospital, Bengaluru, but as far as I know, he's passionate about children, otitis media in children, pre and pediatric age group, because he was the editor of the bulletin which was published by GSK quite some time back. Number of issues were there, and we have a panel, panel of very knowledgeable persons: Dr. Gyan Ranjan Nayak from Chandigarh, Dr. Ilam Bharti from Chennai, Dr. Neha Mishra will also be there, Dr. Vidya Sagar from Vijayawada, and Dr. Vinay Kumar, who is a pediatrician from Chennai. I welcome you all to this event today, and I hand over the microphone to Dr. E.V. Raman sir to kindly introduce our speaker.
Good evening. Thank you very much, Dr. Gautam. You and Vijay have done stellar work in organizing this wonderful web series of varied topics, keeping your academic work of the IAOHNS alive even during this difficult COVID times. And I must congratulate you on the wonderful topics you've chosen. And thank you very much for including me in this wonderful journey. Today is of special importance because pediatric otolaryngology is in its infancy in our country. And IAOHNS has committed itself to popularize this area. And this is a right step in that direction. And infections and children go together. And I'm very happy to tell you that we have the keynote speaker, that's Dr. Neha Mishra, our energetic infectious diseases specialist from Manipal Hospital, Bangalore. She has founded the department, made her presence felt very subtly. It's difficult to be an infectious diseases person in a multi-specialty hospital and get things done with a smile, as I was telling her in the recent past. She has done her MBBS, MD, and done a fellowship in infectious diseases from the prestigious CMC Vellore. And she's come here today to share her thoughts. I also welcome the other panel members, and I probably will introduce them when we get to the panel. Neha, you're invited as a special guest to be part of the panel. So maybe you can start your talk now, and I'm sure you'll enlighten us in the next couple of minutes, 20, 30 minutes.
Thank you so much. Thank you to the team for having me here, and it's an absolute pleasure to be a part of this discussion. In next few minutes, like 30 minutes odd, I'll try to distinguish how to, differentiate and work up different viral infections among all the age groups. I'll be talking in general. So, yeah, viral respiratory tract infections and its relevance in COVID era is my topic. And
sorry to interrupt you, ma'am. Your voice is a bit low.
Is it?
Your voice is a bit low. You can have it louder. I like to hear everything you say.
Am I audible now? Yeah.
Yes, ma'am. Please go.
Okay, I'm so sorry for that. Yeah. So I'll be taking you through viral respiratory tract infections and its relevance in COVID era, and I'll try to see and talk about how to differentiate different viral prodromes. So for the ease of the talk, I have divided it into 3 to 4 subtitles. So we will differentiate them symptomatically, then try to differentiate them diagnostically, and then try to differentiate them on the treatment and prevention basis. So coming to symptoms, see, we all know that most of the viral infections, uncomplicated viral infections, usually last for 5 to 10 days, and most patients of viral URIs are in general febrile for first few days, and then like 48 hours or so, and then they become afebrile. If the fever is present, it tends to occur on the first 2 days of the illness, and then there is a concert of constitutional symptoms which resolves. And if at all there is a secondary bacterial infection, then the person has a double hit, or the second time when the patient's symptoms become bad. So in such cases, usually there is a secondary bacterial infection. Otherwise, in general, after 48 hours, most of the viral prodromes do not show symptomatic febrile illness. So since H1N1 has one of the major culprit pre-COVID era, or influenza, seasonal influenza A and B has been the major culprit of these viral infections, severe viral infection, I must say, in the pre-COVID era. So we have seen that these numbers of H1N1 and influenza A did come down during COVID season. So starting from 2019, we saw that the number reduced to something as less as 778, that is less than 1,000 in 2021. And the number of deaths due to H1N1 only remained up to 12, which again in 2022 has risen. This is as of on 31st of August 2022. The number has risen to 6280, and the deaths are also more, that is 175 due to H1N1. So with the COVID, there was decline in the number of influenza that we saw, and also other respiratory viral illnesses. But then as the COVID pandemic seems to be settling, the number of other viral illnesses seem to be increasing. So this is the pattern of other viral diseases that you can see. For RSV, we can see that there was the black dotted line indicates the RSV in 2019, and the red one indicates in 2020. We can see the numbers of RSV declined. The numbers of rhinoviral remain almost more or less same, but there was still a steep decline. Then also the number of parainfluenza viruses, they also were lesser than previous. The number of flu infections were also lesser than normal. The number of 2019 flu A, flu B, both, there was a declining trend. Adenovirus actually was almost not detectable throughout the year. And even metapneumovirus, there was a similar trend. So we saw that over the period of 2019, after 2019, once the pandemic hit, the number of viral infections that we see in general, like RSV, rhino, parapneumo, they all kind of came down. And as the pandemic settled, then what happened, we'll see in next few slides. So why did this happen? Probably most of the non-pharmaceutical intervention during COVID pandemic, like wearing masks, washing hands, following distancing, reduced the prevalence of other viral prodromes as well. The significant decrease in the numbers of pediatric admission was seen in France, Finland, USA, Brazil, Morocco, and across all the countries, including India. So the reason behind probable drop in numbers of all the viral infection is the NPIs, that is non-pharmaceutical interventions. Then what happened as the pandemic started to settle? As I was talking, there was the largest reduction observed in communicable disease, and that is about 76%. And non-infectious diagnosis also came down, but that was probably because of lack of reaching out to the hospital or people visiting the hospital less often. So the positivity rate of most of the virus decreased during the post-COVID pandemic, with largest decrease in influenza A, followed by adenovirus, rotavirus, and influenza B. Then after that, the positivity rate of respiratory syncytial virus and adenovirus, which is enteric in nature, increased in post-COVID era, as soon as the non-pharmaceutical measures were removed or relaxed. So you can see even in these charts, in the pre-COVID era and the post-COVID era, the rhinovirus and RSV, the flu A, flu B, they did touch the baseline and they did become very less during the COVID pandemic. But as soon as the NPIs or the non-pharmaceutical interventions were relaxed, the numbers started going up. And in the summer of 2021, there was an out-of-season resurgence of RSV virus, which was observed in USA. and it was more prominent in the younger children, older children than 5-year-old age. So the reason being probably the relaxation of NPI led to the resurgence of common viruses. Now, did the co-infection, I mean, we are trying to talk about what happened to the other viruses when COVID was around, and what happens to these viruses if they happen concomitantly with COVID. So in this particular multivariable model, you can see that they tried to see what happens to the co-infection all across. So this was a retrospective analysis done in about 212,466 patients, and it was in UK. They studied most of the patients retrospectively from 2020 to 2021. And then they saw that any infection occurring in in presence of SARS-CoV-2, there was a significantly large amount of increase odds of death. Although the p-values remain not non-significant for most of them, but you can see here with the influenza virus with weighted multivariate analysis, they could find the p-value being significant in such cases, wherein the COVID occurred in concurrence with the influenza. So that means the odds were quite high for co-infection leading to mortality. Okay, so this was about what happened to the viruses. Now, how do we have to talk about in next few slides, I'll talk about how do we differentiate them. So what is the symptom-based differentiation between SARS-CoV-2? So what is our prime target as clinicians? Once the patient comes to us, we are supposed to tell whether you have, what do you have, and we have to treat them accordingly. If they have, we are suspecting a viral prodrome, we have to treat it accordingly. Among viruses, we have few major viruses which we are very concerned about. For example, if there are respiratory virus, right now in the current day and age, we will be more concerned about, earlier we were concerned about influenzas in a comorbid population. Right now, we are also concerned about COVID. So apart from that, most of the viral diseases are treated symptomatically, and they do not have any specific virus treatment. Hence, we have to suspect these two more, and we have to try to differentiate who has this more often. So this is a study which was done to see in the early presentation, what is the distinguishing factor between the COVID and other respiratory tract infections. So this first bar indicates COVID negative, and second bar indicates COVID positive individuals, and the gray bar indicates the patient who said these symptoms were not there, and yellow bar indicates the patient who said that symptom was there. So in COVID negative, you can see that the most of the patient did not have loss of taste and smell, while in COVID positive patient, around 50% patients did have the symptoms. Similarly, the temperatures were high in both of them, more being in COVID. Muscle aches were prominent in both of them, more being in COVID. Headaches were more common in both of them, again, more being in COVID. Cough was more common in both of them, around similar numbers in COVID and non-COVID, but still there was a slight difference in COVID. Okay, so most of the times, the symptoms were similar, apart from the significant difference in loss of taste and smell, which also again may occur in other viral infections, but it did occur more importantly or more commonly in COVID patients. This is occurrence of symptoms they tried and checked. So this red bar indicates patients who have COVID positivity, while blue bar indicates patients who do not have COVID positivity. The numbers were 484 here and 904 here. So they saw that who had cough, temperature, taste, loss of taste and smell, dyspnea alone, and who had the combinations more prominently. So among this, again, I would try to say that, see, the three symptoms, cough, temperature, loss of taste or smell, was more prominent in COVID. And even temperature and cough was more prominent in COVID. Loss of taste and smell was more prominent in COVID. Apart from these three things, no single symptom was suggestive of COVID or to differentiate COVID from non-COVID individuals. So again, this leaves us with a question. There's nothing for us to differentiate between them. Similarly, they tried to age divide and see if there was any difference. Again, the only thing that fell into place was probably the triple symptoms of cough, temperature, and taste loss, and in some individuals, taste and wherever we combined loss of taste and loss of smell, it kind of went more importantly up in the patients with COVID. Other than that, it was similar instance in all three of them. So, characteristic feature of differentiating these two, incubation-wise, influenza has incubation of 1 to 4 days duration. COVID-19 has incubation period of 2 to 5 days duration, and up to 14 days it can increase. You can see people getting disease after 14 days of exposure, and as long as 21 days of exposure as well. So, infectivity 1 day prior to symptom, people with influenza will be rendered infective, and till they remain symptomatic, they will continue to spread the infection. Hence, they have to be isolated till they are symptomatic. Then COVID-19, we presume that they are actually infective till 2 to 3 days prior and up to a week later, approximately, of the symptom onset. And that is their period of isolation. Ideally, they should be isolated till that duration time. Seasonality, influenza definitely has a seasonality defined. We'll be seeing in next few slides. COVID-19, we have had 1, 2, 3 waves, but we don't know whether it is a seasonal virus yet. There are some databases or some amount of data that suggests that it could be a seasonal virus and we will need a regular vaccination against it, but it is yet to be proven with the hard evidence. Spread, both of them spread through similar mode of spread, that is respiratory secretion, droplets and aerosols are the mode of spread. Complication, individuals with more comorbid condition, elderly, pregnancies are at more risk of developing complication in influenza as well as in COVID-19. But COVID-19 may cause complication even in healthy individuals. We have seen that and experienced it. So extrapulmonary symptom may occur in both, and even COVID-19 during the third wave, we have had more amount of GI symptoms coming to us with COVID-19. Signs and symptoms. Again, there is no one single sign that differentiates between COVID and flu. And there is no one single thing that will tell that it probably is COVID or it probably is flu. Everything you see will say present in both, apart from loss of taste or smell. So loss of taste or smell is something that probably may put COVID-19 at your list of suspicion higher, and flu again at lower. Again, after saying this, no, I would say that loss of taste and smell happened in first 2 waves more often. It does happen with few patients now, but it is less common. So to complicate our matter further, we were still not able to differentiate between the type of other infections and COVID. There is a difference in between the COVID variants itself. So COVID, we saw that there were different mutations, newer strains that kept coming into COVID era, and first wave, second wave, third waves, they were caused by different type of strains like Alpha, Delta, and Omicron. So as the strains were different, we did not expect, but that's true that the symptoms were also drastically different. So this particular study tried to point out what were the differences between the 3 waves of COVID-19 and how the changes in symptoms and changes in mortality rate occurred. So they did not, in this, we saw that first wave occurred in March 2020, then second wave occurred in July 2020, and after Christmas 2021, they saw the third wave. So changes in symptom, fever, cough, sore throat, chest pain, muscle pain, confusion, dyspnea, headache, anosmia, and ageusia was the primary predominant symptom during first wave. Second wave again become a little bit of common cold, fever, pneumonias, dyspnea, cough, sudden death, and lower respiratory tract was more involved in the second wave. That was associated with very increasing rate of mortality, and we all saw how devastating the second wave was. Third wave, the flu-like symptoms and neurological effect were more common. So upper respiratory tract involvement was more predominant symptom, confusing us further with other viral infections and making it even more difficult for us to distinguish between them. Although the good thing that happened with this is that mortality rate dropped, and most of the things were manageable with the symptomatic treatment alone. So when we entered the pandemic, we know that we were dealing with an unknown pandemic. We took all the high precautions. It was mandatory to stay at home. Increasing rate of death rates we were seeing. We saw that everything stopped and held still, and we did not have enough information to kind of how to deal with it, what to do with what we had. So, and at that point we did not have even vaccination available. So once this while we were into the second wave, there was decreasing rate of mortality, decreasing rate of death. Vaccines became available. People started resuming normal life and having alternative plans as well. So we did have an increasing sense of danger to begin with, which decreased eventually, but left us probably more vulnerable with other infections. So these are the different strains that we have seen so far, and we know that there are differences between the vaccination properties, reinfection rates, transmission rates among these strains itself. So we know that B117 was highly transmittable. It has moderate reduction in neutralization, and even the seroconvergent is very bad for this. So and disease severity does develop very quickly. B13.351, the mortality reinfection rates are higher. It transmits very fast. There is high reduction ability in the neutralization, and again similarly. P1, the reinfection rates are higher, greater transmission, higher reduction ability in the neutralization. B11529, reinfection rates are higher and greater transmission. We don't have data about high reduction in ability of neutralization. So all these things stated that there is a problem with not only when we are trying to distinguish between the viral infections, there's not only the problem with distinguishing it from the other viruses, we also find it difficult to distinguish it from its own different fellow strains. So it's not probably clinically possible to distinguish them too much. To end this section of my thing, symptomatically, I think I would say the only symptom that can put COVID little apart from other viral infection is loss of smell and loss of taste. There was a reduction in the number of viral infection that was happening during the COVID, but as soon as the non-pharmaceutical interventions were removed, the numbers again went up and high, and probably are back to normal. So now coming to diagnostics. When I say diagnostics, there are several scales like Jackson scale and Wisconsin upper respiratory symptom survey scales, which are used to see if the patient falls into the criteria of viral infection or not. They are usually used for clinical trials and study definition purposes, but they have poor sensitivity and specificity both. That is probably VURSS scale is around 85% to 44%, 85% sensitive and 44% specific, and Jackson-Colt scale is around 81% sensitive and 66% specific. So with this, again, it becomes difficult to distinguish it on the clinical, patient once the patient comes to you without doing a test. So how do we distinguish? So here comes the role of PCRs and molecular diagnostics. Influenza-specific assays are available, and they are indicated by temporal epidemiology. Wherever we can fit the patient into this, there is a season, influenza season there. Patient has several people within the house which are sick, and also has high-grade fever with upper respiratory tract infection, and we are suspecting influenza strongly, then I think it makes sense in people who have multiple comorbid condition to do the test of influenza. There are other viral PCR and bacterial cultures. We can also do bacterial cultures for nasal swabs and washing, but they may not be very useful because, again, even if we diagnose that somebody has rhinovirus, what will we do? We may still give him paracetamol and ask them to go home. Molecular assay for the detection of many common cold virus pathogens are available. We can detect rhinos, RSVs, metapneumos, everything, but we don't have targeted antiviral therapies approved for use in uncomplicated upper respiratory viral infections. So everybody coming to OPD need not be tested for the same, and we need to probably ration our testing for only people who really need it, like immunocompromised, somebody who has a malignancy, somebody who has underlying condition, who is on dialysis, or is a diabetic, something like that. Detection, again, PCR picks up every virus that's sitting in the throat, and detection of viral shedding does not necessarily correlate with the clinical disease. So yes, you may find some virus sitting, or for example, rhinovirus. It is known that rhinovirus is extremely common in asymptomatic adults, and even people have no zero symptom, then also they'll have 6% of asymptomatic adults will have that virus, and 35% of asymptomatic pediatric children will have the virus present in the throat despite the fact that they will not be symptomatic. So doing a viral PCR without a right clinical setting may not be the right thing to do. Yes, we can use the influenza PCR specific assays just to diagnose our patients and treat them, because that is where we have the treatment. But otherwise, we need not treat everybody with uncomplicated upper respiratory viral infections, need not diagnose them. Lung scans and sinus scans, not routinely indicated until unless we are suspecting a lower respiratory tract infection. If examination suggests of consolidation or parenchymal involvement, then yes, it becomes important and mandatory to kind of do a thoracic scan. Sinus scan, again, I believe it's not important in every person presenting with upper respiratory tract infection, because abnormal scans may be seen in 42% of asymptomatic individual also. So we have to probably think and utilize that modality as well. So that was for testing other viruses. Now coming to testing COVID. COVID, we have a PCR-based test and we have antigen test. So PCR-based test actually picks up the diagnosis of current infection. We use a respiratory sample. It has very good sensitivity, and its performance depends on type, quality, and duration of illness. So that is what will decide. The good sample collection will decide the rate of positivity rate of this. Although there is a false negativity rate of about 5 to 40%, that depends from person to person, and quality of specimen also. Time to perform such kind of test is somewhere around as quick as 15 minutes and to as late as 8 hours. There are different type of machines that are available that does it. So serology is basically used or utilized to look at the prior infection, and of at least 3 to 4 weeks. The sample usually utilized here is blood. It has variable sensitivity and specificity. Detectable antibody may take several days to weeks to develop, and they may even develop by 14 days of onset of symptom. There are cross-reactivity to several other coronavirus. Individual results should be interpreted with caution, and we should see the setting, where the patient is in, and whether that report has to be considered important or not important on the case-to-case basis. Again, it takes somewhere around 15 minutes, 2 hours to perform the test. Antigen test is again a diagnostic test. It is less sensitive than nucleic acid test, that is PCR test, but sensitivity is highest in symptomatic individual within 5 to 7 days of symptoms. So that is why it is, at point of care test that is used at several settings, and that is what people have in that home-based lab test. They keep doing it nowadays very often. So it is less than 1 hour time. You'll have result in few minutes if you do this. So diagnostically, coming and trying to conclude, diagnostically, we may try to diagnose influenzas, we may try to diagnose COVID, but whether to diagnose other things, other viral infections, which are very common, we have like 100 serotypes of rhinoviruses, whether it is important to diagnose them always, the answer is actually no. Coming to treating them. So treating influenza is easy. We just have to give a Seltamivir, and first it has to be given twice a day for 5 days. If you are doing it as a prophylaxis, it should be given for 7 days. No contraindication in general. And we have several studies telling us that the dose increase even in obesity or people with a high body mass index, they need not use it in a higher dose. So 75 mg twice a day is sufficient. Zanamivir, Peramivir, and Baloxavir are other drugs which are not very easily available in India. Zanamivir was, but I don't think so it is easily available now. So Oseltamivir remains the drug of choice, and this is the adult dosing. For children, it is half the dose. You have to use 30 milligrams twice a day at least. Depending upon weight, you have to try and calculate. So treating influenza, whom to treat? Should we give everybody who comes to OPD, give oseltamivir to them and ask them to take it because they have flu-like symptoms? Answer is probably no. On outpatient basis, at people who are at higher risk of complication, we'll show the chart who is at higher risk of complication in few more slides. They should be started on treatment regardless of duration of symptoms. We should always remember the earlier we start antiviral treatment, the better it is for the patient, and the outcomes are always more favorable in that case. For hospitalized patient, we have to initiate treatment as soon as possible. If in the higher risk group, we should start it regardless of the duration. So now we were talking about antivirals. I'll also shortly talk about where should we give antibacterials. As I said, that most of the viral infections are viral and they don't need antibiotics. So viral infections usually occur due to inoculation into the conjunctiva or nasal mucosa, replicates within them within few hours, and sometimes people are symptomatic on the same day. They extend to PNS via nasal blow, and the commonest agents are rhino, parainfluenza, and influenza. The symptoms may remain till 7 to 10 days. The incidence of bacterial infection is only 0.5 to 2. It occurs due to mechanical obstruction, impaired mucociliary clearance, allergic rhinitis, and dental infections. Common agents are strep, our good old friend strep, Haemophilus, and Moraxella. Whenever we suspect AVRS, it should be the duration of less than 10 days, symptom with no further worsening, fever settling within 48 hours, and clear nasal secretions. If we suspect a bacterial rhinosinusitis, it should be persistent symptom lasting for 10 days with no clinical improvement and biphasic pattern or doubling worsening. So how do we treat it? Acute viral do not need an antibiotic. We must remember always analgesic, antipyretics, saline irrigation. Intranasal glucocorticoid, it can cause epistaxis and sore throat. So use with caution. Saline, ipratropium bromide, these are the options. I'm sure you know, the ENT teams know it better than I do. Oral decongestant, we should avoid it in patients with cardiovascular diseases, hypertension, ankle closure glaucoma, blood and neck obstruction because of sympathomimetic effect. Intranasal decongestant, there is always a rebounded congestion or mucosal damage that can occur with that. Hence, we have to again use it very carefully. Antihistamine can lead to overdrying, thickening, difficult to mobilize secretion, increased discomfort. They can also cause drowsiness, cognitive impairment, and anticholinergic effects. That's why we have to be careful. Mucolytics do not have many, studies that support it, but people still use it with some benefit. I think we need RCTs to help us believe that it works. So if somebody has a clinical diagnosis of probable, first we should be sure that the patient will come back for follow-up. If you think that they will not come back for follow-up, then you better initiate an antibiotic. If you're seeing a patient with complicated comorbidities and multiple past history of multiple LRTI progressions. If we feel that patient will come back, then we probably look for improvement. If there's no improvement, then that's the right time to initiate an antibiotic. Diagnosis is mostly clinical. We don't order CTs, and we don't need an imaging as for diagnosing a uncomplicated viral infection, upper respiratory tract involvement. So as per IDSA also, if there is no improvement, then we give an antibiotic. Otherwise, there's a symptomatic treatment that is recommended. ABRS also may be self-limited disease. The patient may improve without any antibiotics. Systemic reviews and meta-analysis have found that many patients with clinical diagnosed ABRS improve without antibiotic within 2 weeks. But if we don't want to wait for 2 weeks, we can treat them with amoxicillin and amoxiclav. Penicillin allergies can use doxycycline, clindamycin, and respiratory fluoroquinolones. But macrolide, azithromycin, our favorite drug, and Septran are not recommended if we are actually thinking that strep pneumo can be the cause, because there is a high resistance of these drugs for S pneumo. So detection of H influenza type B capsular gene and presence of fimbrial gene suggests virulence potential for these isolates. That is probably the reason azithromycin and Septran no more are the drug of choice, although they are very rampantly and they're used very rampantly. So patients who are at a high risk of resistance they are usually elderly. There are geographical location wherein the penicillin non-susceptibility is more than 10%, hospitalization of at least in last 5 days, antibiotic use in previous month, immunocompromise, previous multiple comorbidities, and severe infection. That is, there are signs of symptomatic systemic toxicity. So bacterial pharyngitis again is another indication wherein we need to use antibiotics. Group A strep, group C and G strep, they are the reasons where we should definitely consider utility of antibiotics. Bacterial, again, we have to look very carefully for the warning signs, supportive care, and again, antibiotic utility should be considered depending on case to case. Supportive treatment like lozenges and spray, these things are again questionable and doubtful. NSAIDs, PCM, decongestant. We need not use unnecessary antibiotic unless there are adequate reasons for us to use it. So treating COVID, we have several drugs, several pros and cons and discussions in past few 2 years, 2 to 3 years. We have nirmatrelvir and ritonavir combination, remdesivir, and we also have convalescent plasma, molnupiravir. All these drugs have been tried, and few of them are of utility. We don't have this combination of Paxlovid, that is nirmatrelvir, ritonavir combination, but that has been proven to be most promising drug so far among all the antivirals. After that, remdesivir is actually very promising, but the reason is the problem with remdesivir is that it requires hospitalization. Coming to preventing, this is last part of my talk, preventing the diseases. See, we always understand, I'm sure as pediatric, you all are working with pediatric age groups, so it's not justified for me to explain you the importance of vaccination, but for the audience who are listening and who may not be part of pediatric forum, they must understand that always and always and always prevention is better than cure. So if we can always try and prevent something, it's all better than try to deal with it at a later date. In India, there are 2 types of categories for influenza vaccination timing. It is depends on northern hemisphere vaccine, southern hemisphere vaccine. In India, there are usually peaks during the monsoon and secondary peaks during the winter. So the actual timing of vaccination is always in question, or it is always doubtful. As per WHO, we should be vaccinating our people in April, but the answer to when to vaccinate is whenever possible. You catch the patient and vaccinate them. So who should get influenza vaccine are who are at high risk of development of complication. For example, children less than 5 years, adult more than 65 years, and people who are pregnant or up to 2 weeks postpartum, residents of nursing home, resident of all people with medical comorbid condition, underlying structural lung diseases, neurological and neurodevelopmental conditions, heart diseases, blood disorders, endocrine diseases, kidneys, liver diseases, metabolic disorders, practically everybody with any comorbid condition. So everybody can get a benefit of this disease. And we know with the research in past that if not preventing, it definitely reduces the severity of disease. For COVID, I think vaccination is a long topic, but we have 2 vaccinations available in Indian setting. One is Covishield and one is Covaxin. For children, we have Corbevax as well available now, and it is being given to children also. So I won't go into that because COVID-19 vaccination is a long topic in itself. But if anybody has not taken the vaccine, I think they should promote and advocate vaccination. To summarize my talk, it is difficult to differentiate viral prodrome on clinical grounds. The molecular diagnostic may be helpful, but it should be utilized in a correct clinical setting. Specific treatment is not available for most of the viral disease except influenza and COVID. Hence, probably diagnosing them and treating them and putting a high index of suspicion for these 2 viruses is more important. If at all we are suspecting them, suppose I am suspecting somebody to have influenza who came to my OPD, and I want to send a RT-PCR for influenza. So we must understand the time is very important for influenza or any antiviral for that matter. The earlier we start, the better outcomes we'll get. Hence, there is no reason for you to wait for the test. If you are suspecting flu or influenza, rather start the treatment and then wait for the result. If the result is negative, stop the treatment. There won't be any harm. But specifically in a patient or population who is at higher risk of complication, hence, all the people with comorbid conditions, all the people with underlying immunosuppression, in them, if you're suspecting influenza, I think we should treat it first, wait for the result. If that comes back negative, we should stop it. COVID, we can't do that. There's no data supporting that. But in influenza, we know that early treatment can reduce the mortality rate. And last point, but not the least, prevention is better than cure. Please promote vaccination. So that brings me to the last slide. I'm really thankful for this wonderful chance to talk. Wonderful chance that I got to talk with these people, and I will be happy to take any question, anything that I can help you with. Thank you so much.
Phenomenal talk, Neha. I mean, you just educated us so much. We know that we do not know so many things, and we need to know because we are at the interface of various disciplines. But then, as far as we ENT surgeons are concerned, in fact, there was a survey long back on the lighter side about people who do not understand the usage of antibiotics. Now, the number one ignorant people were supposed to be cardiothoracic surgeons, and ENT surgeons were listed number 2. So you've come and delivered your talk to the right audience. Thank you very much. And it's very nice that you have highlighted the fact of this differentiating between the common garden viruses and COVID. And in COVID, also the various strains, how each wave brought in a new set of symptoms, confounding the whole problem. Hopefully, we should understand all these things better, and so that we use our tests, etc., very optimally to pick up the right kind of patients to be treated. And more important than that, for the ENT audience, most of our problem starts initially, as Dr. Neha has pointed out, with the viral infection. And then subsequently, the bacterial infection catches up, and then they come to us. So where to use the antibiotics, where not to use the antibiotic, where you should have watchful waiting for the patient to improve, etc. So I think it was an excellent talk. And my co-panelists who are on the board, in case you have any questions, we can start with that. And later, Dr. Vijay probably will involve the audience in general. Deepak, Vijay?
Yes,
any
sir.
of the participants?
Till now, no questions. I would request the audience to post the questions in the box on the right side of your screen. So we will proceed with the panel, sir.
Sure. We have a large number of people watching according to the numbers given by Dr. Vijay. Thank you very much for such a big, large crowd. Congratulations.
It's a mixed crowd of both pediatricians and ENT.
Fantastic. Thank you. So,
can we stop sharing the screen, please? Yeah.
Okay, let me try to share screen. I'm just checking my slides. Can you see the slides? Are the slides moving or not yet?
Yeah, we are seeing the first slide.
No movement?
Yeah, not moving now. Yeah.
I have the same problem, so we need to sort that out.
You go to the wine glass and then slide share mode.
Let me go.
In the lower bottom.
Where is this wine glass?
Just beside that 72%.
Where is the 72%? I'm not able to see.
The lower right bottom.
No battery.
First start the presentation and then share it, sir. That may help.
It's better to share the entire screen.
Yeah, you start the presentation now. Okay.
You have to share again, sir. Your slides have gone off.
Yeah. Gautam, are you sharing the screen? And
So your slides are.
We are not seeing your slides.
yeah, I think somebody is helping me.
Did you minimize it by accident?
Yeah, I'll just put the. Yeah, it's here.
Yes, sir. We are seeing the first slide. Either you can click on the slide or you go to the wine glass in the bottom near 72%. Yes, yes, yeah. Click that. Yes.
I think somebody is remotely controlling it. You can do that because mine is not working.
So you can go to the slideshow on the
Top.
top. Big there, sir.
Not working, sir.
No, my cursor is not working. I think I handed over the control to somebody who's helping me. Can that person continue to help or?
Yeah. Just a minute.
Okay.
But it's not working. At least you can move the slide in the right side and click on it.
Yeah, you can click over the slide. Why the panel slide you click?
So now, can you try, sir?
Yeah, 1 minute.
And try the wine glass. You can click over the.
Why
slide.
the panel slides?
Yeah, why the panel slide?
Okay.
Ram, sir, nothing to
No,
rush.
the cursor is not working.
Because we are above 60. Nothing to worry.
No. This particular slide, nothing is working on this. It's hanging.
Okay.
I thought somebody took over the control. I said I gave permission. That's what I was. Is somebody at the back this thing helping or?
I think most likely Dinesh should be working on it.
Can you try again, sir? Now I think share screen stop.
No, I think I'll have to go
Can you
back.
share again?
Yeah. You do the share screen.
No, it's this thing is entire hanging right through. It's not
Can
moving
you
at
have
all.
a copy of your presentation?
You have to either mail it or WhatsApp it to somebody.
Yes, sir. You
Let's
can
do
start
that.
the discussion with the question, and in the meantime, you mail it to me. I will share the screen.
Okay, let me see. Just give me a second. I have to go to. Okay. I think my computer is hung. Just give me a few seconds.
Meanwhile, you can ask the question to Dr. Ilambarthi sir or somebody.
Yeah.
And
no,
they can
do
keep
this
discussing
because I
it.
have to send this quickly because we are wasting people's time.
Maybe if you have any questions to Dr. Neha, we should also can.
Yeah.
Yeah.
So can I ask a question to Dr. Neha, please?
Yes,
Yeah,
sir.
please.
If it is okay? Yeah. Hi, Dr. Neha. Wonderful, wonderful presentation.
Thank you.
Really, really enjoyed it.
Thank
Don't take me wrong, just to kill the time, I'm just asking this question, but it was an awesome presentation. My question is, like in acute bacterial rhinosinusitis, especially in pediatric age group, as you had mentioned, the role of azithromycin or the macrolides is kind of questionable. In chronic rhinosinusitis variant, the role of macrolides has become more of an immunomodulating effect.
Correct.
So does that activity still help in
You
acute
said that?
rhinosinusitis also or
Okay,
not really?
okay.
So,
Okay, but my computer is hanging. I have to switch off and switch on, is it?
so
And also the role of biofilms. Even in the biofilms, I think the macrolides have been proven to be working very well. So even in acute
The
rhinosinusitis or
escape is
recurrent
not working.
acute rhinosinusitis,
yes. So I agree with you. I mean, with you that see when I'm saying that azithromycin are not useful or macrolides are not very much useful in such cases, I'm only talking about acute exacerbations because and that too specifically due to strep pneumococcal. So when that is happening, strep pneumococcal is actually, we know that there is a increase in strep pneumococcal resistance, and there are areas with more than 10% resistance to penicillin and more than 10% resistance to azithromycins and macrolides.
Yeah, yeah. Only thing is this thing is hanging completely. I have to switch off and switch on. Okay, you said. Yeah.
So it's predominantly for that subset, sir. And we know that very commonly when bacterial infections are seen in such cases or acute chronic rhinosinusitis is being seen, we suspect them to have more than 50%. Majority of our cases are due to S pneumo. So in such cases, we should definitely refrain from using macrolide as first drug of choice. Although in chronic rhinosinusitis, yes, there is a role of it, and there a lot of pulmonologists you'll find using azithromycin even for preventive at a preventive dose, even for lower respiratory tract infections. So yes, there is some known few studies are there which states that its role is there biofilm and chronic rhinosinusitis for preventive role. That holds true yet, and because we don't think that that happens because of S pneumo. The larger number of RCTs or the good amount of data for supporting that as well is not there. We don't have too much data to support its use in chronic rhinosinusitis, but there is some amount of minimal data saying that it may be useful. And we have probably should do a study saying that whether it is or it's not. But in acute, I think it's not a good choice.
thank you very much.
Dr. Nega,
Yes, sir.
yeah, this is Dr. Ilambardi. Excellent presentation, Dr. Nega. Yeah, since we are we ENT doctors, we regularly see the respiratory infections, especially influenza and COVID, in our day-to-day practice. So we suspect COVID maybe from the clinical symptoms of dry cough, throat irritation, and also the presence of anosmia or agousia. And when we advise the RT-PCR for COVID-19, so now most of the patients are refusing to undergo the test, showing that I have done the antigen test in my house and it is showing negative. And it is very difficult to educate them that if it is negative, symptomatically you are positive, you have to do RT-PCR for the confirmatory test. Then they will tell us that we will do it after 2 days or few days. then they come back after 1 week or 10 days only, bring the antigen test. How will you approach these patients to motivate them to do the test so that we can prevent that? Because the third wave, the transmissibility is very high. Once if they delay for a few days, then the whole family gets. So yeah.
It's a very practical, and the answer is actually very difficult. Most of them still, despite persuasion and despite continuous counselings, they don't agree to do that. In some cases, I do tell them, or I mean, people with comorbid condition, I don't, I ask them to do it no matter what, because they will be scared or worried about them developing severe disease.
Yes.
And or if they have elderly parents, elderly people in home, or some small children, that's again when we can tell them that, you know, it is better for you to do. You won't believe we still have people who are not vaccinated. So to tell such people also, they may be more scared. But then there's a small group where they are vaccinated, they have got COVID once, twice, some people have even got it thrice. Then they have we have people who are vaccinated 3 times. To convince them, I think, is the most difficult task. My approach is that even if you are not doing a COVID test, I tell them to at least isolate. Isolate for minimum of 5 days till you are symptomatic. Don't go to work. And if you don't want to test, it's fine. And even if it is any other respiratory viral infection, most of them, including COVID, including influenzas, including RSVs, they all can cause severe disease in any comorbid patient. So I tell them that if it is a simple viral prodrome, if it is not affecting you too much, maybe staying isolated till you are symptomatic is the better deal, rather than if you don't want to test at all. So sometimes it works, sometimes it doesn't. But yeah, that's what I follow. So
okay. So thank you, doctor. In spite of advising isolation, they will come with the answer. Already elderly parents are in my house and I have got isolated. So I used to tell them, so the isolation means you have to be strictly isolated, but as long as you don't do the test, and unless you become positive, you won't isolate yourself completely. You will take your food in the same table, in the same room, in the same thing, thinking that you are isolating yourself. So you do the test, confirm it, then you will have the fear of spreading to others and you will isolate yourself. So try to do it at the earliest. Thank you, doctor.
Dr. Vidyasagar here. Again, sorry, Dr. Neha. One more question. I think you really stressed very nicely on the role of oseltamivir. Can you just brief us again the specific indications especially for the ENT surgeons or novice ENT surgeons, when we should think about using the oseltamivir? Because we don't use it that common, at least in ENT practice.
I totally get that. See, if somebody is, whenever somebody come to me with a viral prodrome, in my OPD at least, what my major concern is, see, all other viruses we can't treat. Everything else, practically, no treatment for RSVs, no treatment for pneumos, metapneumos, nothing we can treat. So only 2 viruses we can treat. One is to some extent COVID, and to some extent we have definitive treatment and proven result reduction in mortality with oseltamivir used for influenza. So if I'm suspecting, if I have someone elderly, more than 65 years of age with multiple comorbid conditions, coming with proper viral prodrome, wherein I'm really worried about them developing a complication at a later stage, or I also think that they have some lower respiratory tract involvement. In such cases, I ask them to get a test done and simultaneously start them on oseltamivir. This is, I'm talking about adult practice. So in such cases, I start them on at the same time. And once they get the result,
you mean the RT-PCR test, or you mean
RT-PCR, sir?
RT-PCR for influenza.
For influenza, it is very quickly available. We get it within, at some places, in my place, since we get it max to max in a day's time maximum. So you start
maximum in how many days? One day.
So it is available within 12 hours if the patient comes first. Sometimes we can get it in the evening also, but max 1 day, 24 hours it takes. So
and it's very reliable, and it's not having any cross positivity with any other viruses or anything.
Usually, so we check it initially. We ask them to get the take the tablet till the result comes. If it is positive, we continue the tablet, and if it is negative, we can discontinue it, because again, it will not have any role for any other viruses. If it is negative, then probably continuing it may not make sense. So that's what we do or follow for our patients. Even in children, we have dosing available for less than 15 kg weight. We can give around 30 mg, then 45 mg for 20 kg weight children. We can use that dose for them as well. But I think for pediatric, it is little different, because they don't have many comorbid condition, and they are not at very higher risk of developing complications. So we may not be right in doing that, treating them preemptively or treating them as soon as they come to your OPD. In their cases, I think if you're suspecting it high, or mother has it, or father or somebody among the family has H1N1, and you're suspecting that the child may have it too, then yes, keep a high suspicion suspicion index in such patient. And maybe in that case, if mother has, father has, one of them have H1N1 or influenza A, then you can start them as well on oseltamivir depending upon their weight.
Hi, Dr. Megha. This is Dr. Vijay Kumar, pediatrician from Chennai. Since you touched the pediatric topic, I want to just tell that also, because last week I had at least 5 to 6 cases of influenza positive in kids, straight from 1 year, 4 year, 5 years, 6 years. We do get all school going age group. They have persistent fever, more than 5 to 7 days of fever, which is high grade. Even we just say CRP was negative, and if they have a severe cough and cold, and they have a severe symptoms anyway, body pain, myalgia, everything. And when we just checked on day 3, day 5 anyway, most of them are H1N positive. So we started with oseltamivir, and we just do go ahead. Any protocols, we can just go ahead to start early, or we need to just wait for 3 to 5 days. If the symptoms are worsening, we need to start, or we need to just start early when the baby is going to have a positive thing, and we need to start.
See, the thing is, all the antivirals, even for COVID, we know that the antivirals are faster or better when they are started early. So if we know that mother is positive and child has symptoms, we know that probably they will also have the same disease. So in such cases, starting earlier you need not wait for the result if that's the case.
Here only the child is positive first, because of school going age group, they get a cross infection.
Okay.
In the school anyway, and the parents are getting infected little later from the kid. Here it's ulta anyway, and the child is very sick with the respiratory symptoms. Sometimes they have a respiratory distress, sometimes they won't. Only pharyngitis, cough, cold, myalgia, they won't take food, and it's typical symptom of partial COVID, what we discussed previous, what in your slide anyway. We see all the symptoms except anosmia, and the baby was very tired, lethargic, lassitude, and weakness is there, and oral intake was totally nil, and the baby was dehydrated, another thing, and we need to just examine the baby what is happening, and X-ray sometimes we do get infiltrates, and viral LRI was there. And day 3, day 5, we do start the medicines, and the child was having a fantastic improvement within 48 hours or 24 hours of starting the medicine. So we do see the changes.
The child is sick and you are strongly suspecting some viral prodrome, then there's no harm in starting early. You can always start the drug. There are no major contraindication to the drug. So if you are thinking that there is a lower respiratory system involvement, and the child is toxic and dehydrated and has a lot of symptomatic difficulties, as you rightly stated, that he was dehydrated, toxic, lung showing some infiltrates.
Now it's little bit of overusing of oseltamivir in OPD setup, not in hospital setup. What I'm saying now, most of the pediatricians are general practitioners. They start using oseltamivir as the first line, and in day 2, day 3 fever, they start using it, and overusing is there. And we do in Chennai, I can see a lot of prescription with oseltamivir as the first line, even day 1 of fever with some severe symptoms of high grade fever and other thing. We do see anyway how to address this issue.
So day 1, I don't think I don't give to anybody who walks into the OPD. That's not. I don't think day 1 anybody should get it, just because
Still, now it's over counter prescription was there anyway. Even within 48 hours or 24 hours, if the parents are more agitated and they do have symptoms, but we don't even check anyway. Sometimes the practitioners are not checking, and they are prescribing even on day 1, day 2. I'm seeing a lot of prescription with oseltamivir.
I don't think
even with the kids anyway, not with the adults. I'm saying I'm with the kids. I'm just going.
I think for kids, again, I will use very cautiously the utility of oseltamivir in kids. I think I'll be very cautious about using it unless I have a definitive evidence that the child has a lower respiratory symptom, or has severe symptoms, or has no definite contact history, or is looking very toxic, dehydrated, I don't think it should be done in OPD for such patients. Yes, we may
Well,
not.
we start using only in the IP setup, but if we get a H1N positive and the clinically stable patients, we do treat at OP, and we do start it mostly after 72 hours or fifth day of illness, and with negative CRP and other H1N positive, we do go ahead. Sometimes we do have a typical symptoms of flu. It's not an exposure, and the other thing, lassitude, weakness, oral illness, and the babies are very tired, we do start, and we suspect some H1N1 because it costs somewhere around 3 to 5,000, depends on the lab for checking H1N1 and other thing. Sometimes the parents are a little reluctant to go ahead with the test, and we are giving the medicines and other thing.
I think the slide is working now. I think Sarah is ready. I think.
Yeah, we can go ahead. Extremely sorry for what's happened. My laptop has crashed with all the assaults I made on that. Anyway, coming back, and thank you very much, Neha, and all the panelists for asking questions and keeping everyone occupied, and also gaining in knowledge. Thank you very much. So we're having a panel where, am I audible now?
Yeah, yes, sir. Yes, sir.
We're having a panel on a very, mundane day-to-day topic of otitis media. And we've had the pleasure of having what is called as the Center for Otitis Media Research and Education many years back. And we came out with the first National Committee on Rational Treatment of Otitis Media. And what is the reason we are having this particular panel is important. So first slide will be, why are we having this panel? Next slide. Yeah. So the reason why we are having the panel are as follows. It's a very, otitis media is a very prevalent condition here in children especially. And we also need to, next slide. Otitis media, when you say otitis media, is actually a spectrum of conditions. It's not a single entity. And different conditions require different management. And there are different options for the same condition itself. And the problem is that you can't go ahead with an imprecise diagnosis. And unless you have the diagnosis ready, you won't be able to give the appropriate treatment. So many times we have inappropriate treatment or inadequate treatment. And the other problem is, as was pointed out earlier also, increased antibiotic resistance because of inappropriate treatment of the disease with inappropriate antibiotics. And this is one of the most prevalent diseases in the childhood. So we need to have a consensus on how to treat these conditions and understand each of the conditions in the spectrum. So we start off with the first question to the panelists. So how often do you see these conditions is one question, but can I have the next slide? Yeah, so now we must speak the same language. Now we have these conditions. One is acute otitis media, AOM, where there's a rapid onset of signs and symptoms of inflammation of the middle ear. Symptoms are otalgia, irritability, insomnia, anorexia, and fever, otorrhea, bulging drum, impaired TM mobility, TM erythema, etc. And in the other condition is recurrent otitis media, where there are 3 or more documented and separate episodes of AOM in the past 6 months, or 4 or more well-documented and separate AOM episodes in the past 1 year, with 1 or more in the past 6 months. That is the second entity. Next slide. So we have what is called as otitis media with effusion, which is presence of fluid in the middle ear without signs and symptoms of ear infection. That means there are no acute symptoms. The child has got fluid behind the ear. Then we have one more condition, which is a chronic otitis media with effusion, where the OME or otitis media with effusion presenting for more than 3 months from the date of onset, if that is known, or from the date of diagnosis, if onset is not known. So unless we are on the same, we talk the same language, we won't be able to decide on what is appropriate treatment. Hence, these very basic slides for this learned panel. Now we come to the first slide of how often do we see this condition in your practice? We'll start off with Dr. Nayak. In Chandigarh, how often do you see in your practice? It could just be varied depending on a specialty and depending on the region, depending on the season.
Yes, sir. It's a very common entity we generally in the pediatric population who present to our ENT OPD. Patients most of the time who we see, they might not be come for any ear-related symptoms. They might be coming for other upper respiratory tract symptoms of nasal obstruction, mouth breathing. And when we do a otoscopic examination or a microscopic examination in these children, we find that there is some high chances of having, these kids are having a high chances of having some kind of fluid in the middle ear, which could be otitis media, which the parents might not even have noticed. And on asking the provocative questions like whether the child is having, do you feel that child is listening or ignoring certain times, or is you have to say it repeatedly, or the child is using increased volume when he is watching a TV. All these kind of symptoms we have to ask the parents, because the child, many times parents might not be complaining of a child presenting with an ear symptoms. Definitely, yes, many of the children who are presenting with for hearing evaluation for various or at-risk patients, we do have a do a basic audiometric or tympanometry exam test, where they are many times almost 5 out of 10 patients, kids on routine evaluation come out to be having a type B tympanometry. They are a common entity these days, and we should look after these all the various clinical range of these infections in our daily practice.
Obviously, this must be different in the pediatric practice. So what is the pediatric input? Can you just share your thoughts, Doctor?
Yes, sir. Good evening. Pediatric age group from June, once the school started, the scenes are totally different. There are a lot of viral respiratory infection we do come across, and the babies are having a lot of respiratory infection. They have a recurrent respiratory infection. And again, we see a lot of otitis media. Sometimes most of them are having acute otitis media without any symptoms, only otolgia, intermittent, and they have a respiratory infections with the rhinorrhea, low-grade fever, sometimes nose block and other thing. So we do just treat with some basic medications, analgesics and other thing. But because of the increasing infections and recurrent infections, we do come across some chronic otitis media also, and recurrent otitis media. Babies are presenting with all age groups, straight from newborns. We have some 2 months, 3 months with otitis media. Sometimes they have some suppurative otitis media also, and we have some basic with viral infection. We have some acute otitis media and a chronic and other thing. We do all thing they are presenting. For the last 3 months, we have increase in numbers of cases in all types of otitis media we can see. Sir.
Do you find a seasonal variation? I know Chennai most of the time.
Yes, sir, definitely. After the rainy season, once it started in June, definitely we have a rise in respiratory infections, and allergic rhinitis is also rising. And we do have a lot of seasonal variations with the bronchiolitis and other thing. So seasonal variations, lot of things, because previously before the school, nothing was there, and we have only less number of cases. But after this, along with the respiratory infections, we do come across a lot of otitis media cases also. But most of them are limiting, and with the basic medicines they are settling down, but some are having a complications also. Recurrent otitis media also is there, and we need to refer to an ENT surgeon so that they can just help us to just go ahead further.
So having got both the ENT surgeon's perspective and the pediatrician's perspective, let's move to the next slide. What is the incidence as per literature? Around 61 new episodes were seen for children in, it says 100 years, 100 numbers of children, 100 children, and peak incidence in the first year of life. And global AOM rates are higher in the age group of 1 to 4, and 51% occurs below the age of 5. Point of prevalence of otitis media with effusion is 20% with peak at 1 year age. Again, we need to reiterate, the first few statements are for acute otitis media. The last one is for otitis media with effusion, which is invariably missed unless you're looking for it because the child does not have any other symptoms. I'm sure all of us have the same view that there is a seasonal variation. It's quite common, especially in the viral season. And Dr. Neha, are there any specific seasons? I mean, of course, each city is different, where the viral infections increase, and what are the reasons for that? Is it environmental? What is the reason?
Sir, most of the viral infections do show a seasonal variation. For example, our good old influenza is more after the rainy seasons, just when the rainy season is about. So the seasonal variation is just the cyclical. It's a cycle. They come, they replicate, then the season goes away, and then it's a lot of atmospherical components, humidity. All these things also play a lot of role. And in some place like Bangalore, for example, where it's almost humid, not humid, it's almost raining all the time, the infections or viral infection may occur at some amount all through the year. So such places will have some spike of viral prodrome throughout the year. They may not have any seasonal per se variation in these cases. Hence, I guess these viral infections will make a person predisposed or more vulnerable to develop a bacterial infection. So it is all the more important to keep a track of it. So yes, there is a seasonal variation that is followed by most of the viruses, including influenza virus, rhinovirus. You can also see it in RSVs. And this seasonal variations do corroborate with or make the person more vulnerable to develop a bacterial infection.
Can we have the next slide, please? So what are the diagnostic criteria you look for, and what do you think is important is the next question. Vidya, can you just tell us what are the things you are looking for? We are talking only about acute otitis media now. So please restrict your answer to acute otitis media.
Yes. Thank you very much, IAOHNS, for inviting me for this August CME program. We'll go to the question directly. So the diagnostic criteria I use is common for acute otitis media is, number one is otalgia. The child may be crying of pain or pulling the ears, and there could be fever 39 degrees and higher. I would take it as more positive. And number three is otorrhea sometimes. And number four is coexistent nasal block or nasal discharge. These are the things that I commonly look for in a patient who is having acute otitis media.
So I think any other points from any of the other participants, the pediatric point of view again, from the pediatrician, because your first point of presentation, much more than ENT surgeons, for acute otitis media. Hence, the question is again to you.
Yes, sir. We see a lot of cases, as I said previously, they are presenting with an upper respiratory infection most of the time. And commonly we see just an otalgia that is intermittent, which is not continuous. So the common cases, the number of cases which we see is only a mild symptomatic patients, and they have some intermittent otalgia and it's not persistent. Sometimes they cry and they stop. And once the nose block is severe, they have a trouble, and with the nasal decongestion or some analgesics, they settle down. And we see some patients, they don't have any changes in the tympanic membrane, and we don't see anything, and there is no issues with the thing. And they have some mild symptoms. We do treat with basic analgesics and other things. So most common cases what we see are only intermittent otalgia. We can just say this is not a severe otitis media. We can just go through, and most of the symptoms settle down even without some medicines. Also some nasal decongestions or analgesics, they are settling, and the fever is also not high grade. These are the common cases what we see for the last 3-4 months, what we come across in our city in Chennai, I'm saying.
Can we have the next slide, please?
In addition to Dr. Vidya told, that is the clinical diagnostic criteria he has told.
Yeah.
But in all cases, they require the otoscopic or otoendoscopic examination to confirm the diagnosis. They confirm the tympanic membrane congestion, bulging, fluid behind the ear. That also we have to include in the diagnosis. Raman.
So there are a couple of criteria, and I'm glad Dr. Ilambarthi came out with the important thing of examining the ear. And we come to the next slide. Which shows you the otoscope. Otoscopic examination is very, very important. Now, it comes very naturally for an ENT surgeon to use the otoscope. They use it as often as their stethoscope. But unfortunately, it doesn't come so automatically to the pediatricians for various reasons. We did a survey many years back, and what happens is nothing against the discipline of pediatrics. But the fact of the matter is the kind of rush they have, the number of patients they see, sometimes any pain in the ear is presumed, also amongst family practitioners, is presumed to be otitis media, and immediately the whole gamut of treatment is started. So we have to define, and that was the reason at the beginning of the panel we did define each one. And here, of course, an otoscope is important. What is stressed now is a pneumatic otoscopy. So that is the one that we should have. In fact, we had a survey where we asked doctors, mostly general practitioners, how they diagnose otitis media. They did say they use an otoscope, but then we asked them another question, that do you have an otoscope? And they said we don't. So we presume that they are using it, but it's not done. So use of an otoscope is very important. And if it's a pneumatic otoscope, it is that much better. That's what the international recommendations also say. And that confirms the diagnosis. However, there are times where I'm sure Dr. Ilambarthi also must have seen that, sometimes you have wax, so you're not able to see the tympanic membrane. We'll just come to that in a bit as to what the panel thinks about that, because it'll be nice to have your reactions on that. So pneumatic otoscopy, to confirm the findings which have been mentioned here, is very, very important to have a precise diagnosis. Next slide. So that's the pictorial feature which we want to show, but the bulging drum, congested drum, etc., etc. Next. Now we come to the management part, and let's start with, okay, have I left out anyone? I will start with Dr. Ilambarthi himself. Dr. Ilambarthi, can you just, the question is, do you use analgesics?
Yeah. So your question is pertaining to acute otitis media.
Acute otitis media only. We're not talking about anything else.
Yeah, definitely, whether children or adult, they have come with the complaints of pain. So we have to use analgesics. There is no question of using analgesics in all cases. There is question arises whether when to use antibiotics, when to start antibiotics. So analgesics is indicated in all cases when whether they are uncomplicated or complicated AOM.
So what's the pediatric point of view?
Yes, sir. We do just give analgesics. Definitely the babies are crying a lot. We are forced to use it. Even the parents are having more anxiety, and the kids are also crying a lot. And definitely we need to use analgesics whenever the babies are having acute symptoms and there is a consistent cry. We want to use analgesics.
Yes.
So let us see what is the recommended analgesic here. Next slide. So here it says analgesia for good pain control is strongly recommended. Mild to moderate pain with acetaminophen and ibuprofen. Moderate to severe pain, narcotic analgesia, use with caution. And it also adds one more point here, parent-caregiver preference. When you're treating small children, the parents are part of the treatment team, which I'm sure from the pediatric point of view, you'll agree with us that you always have to explain to the parents. The smaller the child, more you have to explain. Probably you explain much more than what is required sometimes to get their confidence. So what is your preference as a pediatrician as far as pain control is concerned?
Mostly we start with paracetamol, sir. If the babies are having a severe pain, we do go for Brufen, definitely. So we will just stick with paracetamol, may help a lot. But in pediatric populations, when they are having illness, most of the time their intake is less. So using Brufen for longer periods definitely may have some issues with gastritis and other thing. So we just put with a caution, so that we have to just give after food. And whenever it's very severe, we need to use Brufen. Otherwise, we go with the common paracetamol. Sometimes we just go with it.
Have you had occasion to use narcotic analgesia? And
No, sir, not much. We don't use narcotic analgesia till now.
Dr. Vidyasagar, your input?
I agree with the statement given by Dr. Vijay Kumar. So most often these kids do respond to paracetamol or a combination of ibuprofen with the acetaminophen. And in severe cases, we may combine. Am I audible? Hello?
Yeah. Very well. You're not audible now. You were audible.
His
Mute yourself.
mic was in mute. So
Vidyasagar, we can't hear you.
I think he's in mute mode, sir. That's why.
Yeah. We should send a message to him, I think. Yeah. I'm constrained because I'm using an iPhone now because of my
How about using a topical analgesic, sir? So,
Yeah, that's
we
the
do
next
use
question.
anyway,
Yeah.
at least, yeah.
Hello? Hello?
Yeah,
Hello?
Vidyasagar, we couldn't hear you for the last few seconds.
Sorry, sir. So there is a point of giving like autotopical analgesics, but it is like Autogon and certain medications which may kind of work, but to be honest with you, when the inflamed drum, it is actually the autotopical drops will not actually take up the medicine. So we most often rely upon the systemic medication.
And once again, with the pediatric input, Dr. Vijay Kumar.
Yes, sir.
Have you used any topical analgesics? And
Yeah,
found
we
any
do
benefit?
give. When the thing is more severe, and we do definitely, sometimes the topical analgesics may have some calm down to the children. Definitely, we are using it. One more difficulty we just come across is, as you said already, that's the ear was totally blocked with the wax. So sometimes we can't visualize the drum properly. Eardrum is not visible, and we need to treat symptomatic treatment. We need to just go ahead. Sometimes even if you are putting a topical analgesic, most of the time it won't work because of the wax. So both difficulties we have to visualize the drum and to just use the topical. So most of the time we just go with an SLD condition sometimes, and with a paracetamol or brufen combination whenever it's needed. Depends on the symptom of the child, whether it's severe or it's mild to moderate.
Dr. Naik, do you agree with what we have discussed up till now? You have anything to add?
Yes, nothing to add much, and already has been discussed. Oral analgesia are the first medication in mild otitis media to be given, and we can gradually upgrade to the other analgesics as the symptoms progress.
And what about a situation which Dr. Vijay Kumar was alluding to? You have a child who is having fever and is crying incessantly, has wax.
Yes.
Would you presumptively treat the child as though the child has got acute otitis media? Would you do that?
Sometimes we go for the clinical sign. We just see the thing, examination. So pulling the external ear, sometimes even the pressing the tragus. If the baby is having a severe pain or anything, because we need to calm down the child, and we need to see. So some certain symptoms may indicate definitely it's going to be a trouble. So then we can just go with at least we are just giving paracetamol anyway for the fever. So that will calm down the child. So even we are not able to visualize the drum properly. So we just go by the clinical symptoms and the patient history, what they say. And they typically say while touching the right ear, the baby was crying continuously. They are not able to feed on that site and all. So then we can just go ahead with it.
Sir, can I add a
Dr.
point?
Ilavarthi, your comments?
Yeah. So most of the parents, they want topical analgesics, but as Dr. Vidya told, the topical analgesics won't act very much. And coming to the point of wax, I have seen many pediatricians' prescriptions treating the wax as the primary cause for the ear pain. But definitely, we ENT surgeons can differentiate wax producing external otitis, or wax is simply sitting in the ear canal, not completely occluding, not giving rise to any symptoms. So, in acute otitis media, the symptoms of fever, malaise, pulling the ear, or incessant cry, that is pointing towards the respiratory infection, whether viral or bacterial, we have to treat that. No need to treat the wax immediately because wax is an incidental finding. If the wax is the causative thing, then on touching the ear, when we press the tragus, the external otitis symptoms we will elicit and we know wax is the cause. But in more than 95% of the cases, wax is an incidental finding and the AOM is due to infective condition like viral or bacterial. So if the wax is removable in adults, it is easier. In pediatrics, it is difficult. So I always tell them to ignore the wax, apply the ear drops, but continue the treatment for infective part. You will become all right. Come after 5 days or 7 days for the removal of the wax.
Thank you, sir. So we go to the next slide, which is the most important part of today's discussion, actually. When do you prescribe antibiotics? Do you prescribe we're talking only about otitis media. I just want to remind the panelists, we're not talking about the other parts. So that is the next question. Maybe we can start with Dr. Lamberti himself.
Yeah. So I do prescribe antibiotics as per the guidelines, actually. So you divide the pediatric patients into less than 6 months. So in most of the cases of if the baby is less than 6 months, I do start antibiotics in the first day itself. From 6 months to 2 years, if the patient is a high-risk patient and if the symptoms are severe, if the fever is high, patient is having severe pain, then I do start antibiotics early. If the child is above 2 years and if the child is a high-risk patient, symptoms are severe, more than 39 degrees centigrade fever, that is highly symptomatic, then I do start antibiotics early. Otherwise, in above 2 years or above 5-year children, and I will do the watchful waiting. So I treat with analgesics, antihistamines, and Epital with the nasal decongestants or saline nasal sprays, and then wait for 2-3 days. And if the symptoms doesn't subside or the symptoms worsen, then I will start antibiotics.
Dr. Vijay Kumar, from the pediatric perspective, what is your...
Yes, I agree with Dr. Ilambardi sir. Just we do follow the same. So children less than 6 months, we do see a lot of suppurative otitis media and the baby is having more symptoms. So we don't want to take into trouble. So we do start antibiotics early, and we need to see the symptoms of high-grade fever and continuous incessant cry, and the baby is not having any other symptoms except the ear pain with a fever, and they have some mild viral infection, we do start. And as we said, till 2 years, we do have the cautious approach whenever it's needed. Depends on the symptoms, we do start antibiotic on day 2 or day 3, depends on the symptoms and the aggressiveness, what is it's going on. So after 2, we do just follow the same. So we see what is it's a mild otitis media, it's not going to do any trouble for the kid. We do just watch and just go ahead with the thing, analgesic, antihistamines and decongestions and all. So if the baby is having, after 2 years, they have high grade fever and there are severe ear pain and the baby can't tolerate the ear pain, another thing. So it's more than 48-72 hours and the babies are currently coming for our OPD. We do start antibiotics.
Dr. Nayak, your input?
Yes, sir.
Any different?
Yes, sir. We have to also, apart from giving the antibiotics, you have to ensure how the parents, whether if you are planning to not to give antibiotic in a particular child, and you should tell the rationale of not giving, and whether the child can come for follow-up maybe after 48 hours. And even if the situation worsens, you give a prescription of antibiotic, and the parents can start on the medication if the child does not improvise with symptomatic management in the initial 48 hours.
On a lighter side, we did a survey as part of the core thing on current practices in otitis media. And some of the doctors said it takes much longer for me to explain to the patient why I'm not giving an antibiotic, so I give it. So that's the truth of the fact. They come with the pre-described things. And this is a real survey we did. The same survey which found that some people said they were using otoscopes, and we asked them, do you have an otoscope? They didn't have. The first question we asked. So these are all the ground realities we must understand. So that is one part. So next is we'll just see what the international opinion is on this. So we'll have the next slide. So this
Can I also add a comment, sir? Or no?
Sure, please feel free. Yeah.
Yes, not only the use of systemic antibiotics, but also the topical antibiotics and antifungals have become irrational in so many times, and that leads on to other problems like automycosis if they have been misdiagnosed, and that is where I think the ENT surgeons play a role in doing a proper oral toileting, confirming the findings what Dr. Ilambarti sir has said, that autoscopic examination or an autoendoscopic examination is a must to confirm the finding of the cartwheel appearance or the bulging of the tympanic membrane, and then treating accordingly rather than misusing or abusing the antibiotics, both autotopical as well as the systemics.
So here, coming to the next slide. Thanks, Vidya. Sorry, please go back to that. Yeah, so I think this is more or less what most of you were trying to say. Of course, practicing in the clinic is slightly more than just following the guidelines blindly. So we all have to be very cautious about when to start an antibiotics, have certain landmarks which indicate that we need to use an antibiotic, and the 2-year rule, six-month rule, and then how long the otalgia is there, the temperature, etc., etc. Plus acute otitis media may come with a notoria itself after all that. So I think we are all agreed on that. Now, the next question is, which is the antibiotic of first choice? And we again go to we'll go to the pediatrician, and then we'll go to Neha, whether we're doing the right thing. Dr. Vijay Kumar, your choice of antibiotic?
So we do want to just use amoxicillin as the first choice. So we just go, whenever we prefer, we just go for plain amoxicillin.
Right.
And when the babies are getting complicated with more of suppurative thing, we just add a
Yeah, we'll come to that. So are we doing the right thing, Neha, by using amoxicillin as the first choice, as Dr. Vijay Kumar has suggested?
So I totally agree with Dr. Vijay Kumar. I think amoxicillin, maximum to maximum amoxicillin clavulinate should be the drug of choice initially, because the subgroup which we will be dealing with is either strep pneumo, moraxilla, or non-typable Haemophilus. These will be the most common group of organism that we have to cover in such cases. So
sorry, go ahead.
Yeah, so I think that usually suffices. If we are suspecting NTHI non-typable Haemophilus more, then maybe adding clavulinate, that amoxiclav is a better choice. Other than that, amoxicillin should suffice for anybody.
So if the other panelists are agreeing to that, we'll go to the next slide and see what the worldwide consensus is. First line is high dose amoxicillin, 80 to 90 milligram per kilogram per day. If the patient has not received this in the past 30 days or has purulent conjunctivitis. And if penicillin allergy exists, of course, what do you do? Ceftriaxone, cefuroxime, cefpodoxime, ceftriaxone. So your comment on this, Neha?
I agree, sir. But I have seen a lot of times it being underdosed. I mean, I practice for adults, so I know that for adult it is hugely underdosed. So utilizing right dose, as you rightly said, 80 milligrams per kilograms per day of amoxicillin will be the right thing to do. Even for amoxiclav, I don't.
How about for the kids, ma'am? So that we do just follow somewhere between 30 to 50. So we don't go to the higher dose initially. So how about we can just go for the kids, because we do have some symptoms of diarrhea and other thing related, so that we have to be little cautious for it.
No, I don't think we should ever compromise on the dosage just because there will be side effects. I don't think that is the right rationale. I'm sure what sir is showing is guideline based, and I agree with that. The right dosage is 80 milligrams per kilogram per day. And that is what should be utilized if amoxicillin is being used as a drug of choice. Anything short of that will either not work or create resistance.
So the high dose amoxicillin, the high dose or low dose is not related to the GI tract disturbance. If the patient is having intolerance to amoxicillin, it is for low dose also. So it doesn't depend upon the high dose. So the high dose of 80 to 90 milligram of kilogram body weight is the correct dose. But in the market, do you have the high dose amoxicillin alone? We have got co-amoxiclav. That is why I prefer, my drug of choice is the amoxiclav, which is available in the high dose formulation, so that it is easy to prescribe. Do you have any high dose formulation in amoxicillin?
No, the maximum 250. Yeah, we don't have much.
If you calculate for a 20 kg pediatric patient, if you calculate for high dose, you have to use one bottle 3 times daily like that.
True. These are all practical problems.
I agree with Vilambarathi sir, because we also use more of amoxiclav than only plain amoxicillin, because many a times we get this beta lactamase positivity. So I think co-amoxiclav is more of a first line drug for us than plain high dose amoxicillin.
The second thing is possibly the kind of patients that a pediatrician sees, the kind of patients the ENT person sees is slightly different. I think we see slightly more serious forms of AOM, and pediatricians of course see in large numbers, and they also see relatively milder cases. But having said that, there has been excellent studies by Dagan, etc., who talk about complete bacterial eradication. So complete bacterial eradication, you need the right dose given for the right time, which we'll come to later. And the differentiation with the conjunctivitis, etc., is all there because of H influenza causing that, and then you move on to the next. Now, everyone agrees with the cefdinir, cefuroxime, and cefodoxime in penicillin allergy patients, I guess. So we'll move to the next question, which has been partially answered. The next slide, please. What is your second choice of antibiotic? So we have to understand sometimes the second choice of antibiotic will become your first choice, depending on whether the child has already undergone treatment at another medical setup, or secondly, you feel that the child needs a second dose of antibiotic because the child has had an antibiotic earlier within the last 30 days or so. So by and large, what would be your second choice across the panel, starting off from Dr. Naik?
Many times, if the child has only received the amoxicillin, just adding a clavulanic acid might work in this child. But as Dr. Vidyasagar has rightly said, and Dr. Ilambati sir, that we generally prefer amoxi-clav combination as they present little later to our practice. If the child has only received amoxicillin, we can have a amoxi-clav. Otherwise, we generally prefer to the either we switch on to macrolides or cefodoxime is the second choice of our antibiotics.
Okay, so we'll just see what the worldwide opinion is. Next slide. So second line, we've already discussed enough about this amoxicillin clavulanate. And when the patient has received amoxicillin in the last 30 days, you switch to the next one. And as purulent conjunctivitis, or has failed first-line therapy 48 to 72 hours. I think we all agree with this particular slide. Anybody having a contra opinion?
No, sir, we can.
Okay. Can we go to the next? Yeah, please.
There are a couple of questions from the audience. I have put it in the chat. You can answer them. That will encourage them to.
Okay, sure. I am a little constrained because of using an iPhone. Vijay, okay. You can just interrupt and ask the question to one of the panelists if you don't mind.
Yeah. So Dr. Balaji from Coimbatore has asked, one suggestion he has suggested, nasal suctioning and freeing of nasopharynx from secretions will give dramatic pain relief. Any comment on that?
Can I answer it, sir?
Yeah.
Instead of nasal suctioning, I think we are talking about the pediatric age group. So instead of nasal suctioning, what we do is saline nasal douchings more than just suctioning, because doing a suctioning at the office may be difficult for them, and nasal douchings will be more easier. It can be easily practiced by parents, and that could actually help them in relieving the nasal secretions and thereby increasing the efficacy of our medical management.
Yeah, to add to that, Vidya. So, hello.
Yeah, go ahead.
Yeah. To add to that, in acute otitis media, it is very difficult to examine the patient itself because they are having severe pain and they are crying. So it is not possible to do nasal suctioning, especially in pediatric patients. So as you have rightly told, so nasal douching or saline nasal sprays are more useful, and which is not going to give any dramatic pain relief as the Balaji questions. Pain relief, you have to give analgesics. And also suctioning is going to help in next few days, not immediately. Not for immediate pain relief, suctioning won't help.
Fine, sir.
It may help with the concurrent nasal symptoms, but nothing else.
Yeah.
So there are a couple of questions on analgesics over the TM. If it is intact, and what will the effect if it enters into middle ear if the eardrum is ruptured in AOM?
Right. Anybody wants to take up that?
As Dr. Vidya already told, if the tympanic membrane is intact, there is no use of putting topical analgesics. It only satisfy the parents who bring the patients that we need some drops to pacify the child. So there is only placebo effect will be there if the TM is intact. If there is a perforation, if there is an otorrhea, then if you use a topical antibiotic, steroid ear drops may reduce the edema and congestion, may reduce the pain.
Okay, so
shall we go ahead? Because
one question, sir.
Yeah, sure.
So what topical analgesic would you suggest, and what will be its effect in the middle ear? That's the question.
I think we should not use. Yeah, go ahead.
Yes, sir.
Yeah.
If there is perforation, we tend not to use it, but the common available market is this Otogesic and Otogon ear drops. I don't know the exact pharmacological names of them. I'm sorry about it, but these are the commonly used ones. kind of more of a placebo effect than the actual act of the medicine.
There is no evidence at all for these to actually work, no scientific evidence, like has been discussed earlier. Can I move on to the next one?
Yes,
Slide, Vijay, with your
Yes,
permission?
sir. Yes, sir. Yes, sir.
Yeah. Next slide, please. How long would you prescribe the antibiotics is very important. What is pediatric practice and what is ENT practice? Let's start again with the pediatric practice.
We
Vijay
do
Kumar,
not
sir?
just give for 5 days. So if the symptoms are more severe and there are recurrent symptoms or anything, the patient are symptomatic again, we do continue for total 7 days. So 5 to 7 days is our course of antibiotic.
Right. I think we'll just go ahead because we're short of time. What is the international opinion? Let's go through that. We've just got about 15 minutes, I think. Next slide, please. So children less than 2 years old or with severe symptoms can have a 10 days course, and then children between 2 to 5, 7 days, children over 6 years, 5 to 7 days. The various studies, meta-analysis and all that to support this, I think that's it. And we need to give it for sufficient time. What is more important is compliance. Within 48 hours, child is all right, the parents stop the antibiotics. So we need to reiterate again and again that this child is going to come back with pain if we don't give it for the total period. And as I was mentioning, Dagan's study where he talks about total bacterial eradication, this is very, very important. Otherwise, you'll have trouble. And Neha, lack of compliance is one of the important things in terms of increasing antibiotic resistance. It should come from your mouth.
That is very, very true. Lack of compliance, and not only lack of compliance, not completing the courses, dropping or taking them as per their wish and will. That all these things add up to. And from our side, I think incorrect doses and incorrect duration prescription we should avoid. From patient side, I think compliance is important. So
we also find now and then that intravenous antibiotics are very liberally used in these children. Some of them even for otitis externa. So maybe, I don't know, what's the viewpoint on this? Have you guys seen this kind of a practice at times?
No, sir, I don't know. In children, I'm not sure, but in adults, it's very rampant. So that, any fever, any pain, small things, and they are just put on IV antibiotics. So I'm tired of paining.
Right. So we need to use these drugs at the right time. I'm just going to the next question. But if anybody has got any other comment, please interrupt me. And
this is mainly to treat the patient's psychology. Patient needs injection for immediate relief or better relief. But most of the doctors use only analgesics as for the immediate relief. Some people use IV antibiotics, but in IV antibiotics use in the OPD setting has to be condemned. For 2 days, 1 day, it has to be condemned, definitely.
Coming to the pediatrics point of view, we don't use IV zone or IV antibiotic in the OPD setup. But when the baby has the severe symptoms, very rarely do we admit the child for the IV antibiotic. But most of the time, if they are taking the medicines properly, they are having a better improvement within 5 to 7 days, and we are continuing as OP treatment only.
So very few selected cases and children having complications of AOM, I think that's justified.
Yes.
Next slide, please. Now we come to persistent otitis media. That is, the symptoms are persisting in spite of giving the medicines for 48, 72 hours. So how do you manage these patients? Shall we go to Dr. Nayak?
Yes, sir. And persistent otitis media, either we need to look whether apart from the compliance, as the pediatrician rightly said.
Very good.
Yeah. And, they have to check for whether the parents are giving the dosage, the adequate dosage, and whether in the divided doses it has been adequately given. If not, if it has been adequately given, then whether we need to reconsider about giving change the antibiotic. Like the second line would need to add clavulanate, and you have simultaneously we have to check for the severity of the symptoms as well. If the child is becoming more febrile, or has the child becoming, the pain has increased in spite of, or is the pain more or less remains the same and the child is still symptomatic, but we can consider of just changing the antibiotics, and whether to admit or not admit all depends upon the severity of the condition. And if we find the child is more severe and requires some admission, we might need to readmit the child and assess the condition and change the antibiotics.
Some quick comments from Neha and Dr. Vijay Kumar on this particular slide.
Yes, sir.
Role of culture sensitivity and role of immunological studies. Neha?
If it is a suppurative otitis media, we do a culture sensitivity just to know that the way antibiotic what we give was correctly working, and we need to just go ahead.
In other words,
Immunological
if there is a notoria.
Yeah, yes, sir.
Okay. Role of immunological studies.
Otherwise, for the normal otitis media, we are not doing any culture sensitivity. For pediatric practice, I'm saying. I don't know
this
about
is
the
for
ENT practice.
this is for persistent otitis media only.
Yes, sir.
And role of immunological studies, you can respond to that. In persistent otitis media, do you have to consider those?
We do just come across because we need to just go ahead with the studies when the patient is having a persistent immunology issues. Definitely, we need to consider.
Now, this is to the entire panel. Have you, I mean, especially the ENT, have you ever done a tympanocentesis and sent it for culture when the child didn't improve after what you thought was optimal treatment? Dr. Ilambarthi?
Yeah, this is one of the options that we have to consider when the patient is not improving, and if your clinical findings or otoendoscopic findings shows that pus behind the eardrum, we do myringotomy, we remove the pus and we send it for culture and sensitivity. And your point, role of immunological studies are also very important in persistent otitis media because it is more common. Persistence is more common in immunodeficiency cases or in immature immune patients. So we have to do the immunological studies also to find out the cause for the persistent otitis media.
Yeah.
And I advocate myringotomy and the culture and sensitivity has to be done if there is a symptoms is persisting or worsening.
Yes,
sir. Can I answer?
Yeah,
can I
quickly,
quickly, sir.
Yeah.
I agree with what Dr. Ilambarthi sir has said. Apart from sending it for culture, the myringotomy and suctioning also breaks the biofilms, and that way also it helps. So yes, in very severe, which is persistent, this has a role.
Yeah, thanks. Sorry for cutting you short. We have a lot of slides to cover. That's the reason I'm in a little rush.
Just a very small comment, sir. For immunological studies, it will be preferably to consider when we are having a recurrent acute otitis media. Persistent, we might not even consider in the first setting after the child is given a medical and a course of probably a myringotomy suffices.
This question was specific to persistent otitis media. You've given all that you could give and still not improving. So you want to find out. Okay, next slide, please.
Sir, can I interrupt?
Yeah.
So we can go up to 8:30, sir, because there are a lot of viewers and almost 750 viewers are there.
Fantastic.
So we don't have to rush it. Everybody is interested, I think. Still a lot of questions are coming. So we can extend it up to 8:30, sir. No issues, sir.
Wonderful. It's better than Punniyin Selvan, I think. Okay. So, we want all these points are important. We don't want left anything uncovered. That was the reason.
Yes, sir.
Role of myringotomy in case of acute otitis media. So we discussed partly that, but again, I want to reiterate the fact, how often do you do it? And when do you do it, etc. This is, of course, to all the ENT surgeons there. We'll start with Dr. Ilambarthi. You want to add anything to what you already said?
Yeah, in acute otitis media, generally we do only myringotomy. We don't prefer to put a ventilation tube in acute otitis media. But it immediately relieves the pain. That is the first point. So patient symptomatically become better. And we obtain material for culture and sensitivity so that we can give appropriate antibiotics for the correct duration. And that is also the second point. Third point, Dr. Vidya told you are by removing, you are breaking the biofilm system also, and you are treating the patient correctly.
So I'm not asking the question to Vidya. He's already stated his thoughts. Now we need to go to Dr. Nayak. Any change? Myringotomy. Because myringotomy for pain relief is not mentioned in these guidelines. So that was the reason I brought it up, because we do it on some occasions at least. 48 hours, the child is not improved, crying with pain, fever not coming down. Is that the practice that you people also follow?
Yeah. Yes, sir. If the child is having a bulging tympanic membrane and in spite of 48 hours or with the change of antibiotics, child is not responding, myringotomy is our way to go for relieving the pain as well as the antibiotics to work. Because with the tympanic membrane is so bulged out and because and it is almost at the point of bursting. Rather than waiting for it to burst and giving a perforation, we can give a controlled cut and let the discharge come out, and so that it can heal properly.
So in these pictures that we have, the second picture probably shows that, the amount of pain, the pressure, the drum is bulging, and some of these children do require what we talked about. And surprisingly, these things are not mentioned in the guidelines. That's why we talked about it. So we'll go to the next slide. Now we go from acute otitis media to chronic otitis media with infusion. Now, one very important point was raised by Dr. Ilambarthi, which I want to reiterate. You do a myringotomy in acute otitis media, there's no need to put a tube there. It doesn't mean every time you do a myringotomy, you have to put a tube. I hope the rest of the panelists agree with me. So we're going into chronic otitis media with effusion. Next slide. So we have to differentiate again, once again, for the sake of the audience and for our sake, signs and symptoms of acute otitis media and otitis media with middle ear effusion. We have to understand fever, irritability, and earache is present in acute otitis media, not present in otitis media with effusion. Fluid in the middle ear is present in both circumstances, and acute otitis media, you have fluid in the ear, both sides, and then hearing loss is present in the AOM, usually definitely present if there is middle ear effusion, and running ears with pus is present in acute otitis media. It's absent in otitis media with effusion. This is all basics, but just to reiterate a point. Next slide, please. So how do you diagnose otitis media with effusion? So here we come to the various ENT points of view. Maybe Dr. Naik, you can take this up.
Yes, sir. As a ENT surgeon, we do a pneumatic otoscopy in these kids, and which is mandatory for for diagnosing otitis media, apart from sending the patient to do a tympanometry. We prefer a pneumatic otoscopy and check for any air fluid levels or any bubbles, or the drum is retracted and there is a loss of shine and the color of tympanic membrane. Doing a otoscopic examination is of utmost valuable. It's a very strong recommendation also to do a otoscopic evaluation and a pneumatic otoscopy.
So let's get the pediatric point of view. I think ENT point of view will be almost similar amongst all the doctors here. So Dr. Vijay Kumar.
Yes, sir. We do just do otoscopic examination whenever it's needed. As a pediatrician, I do agree doing an otoscopic examination is difficult for us in our busy schedule. Definitely, we have a lot of numbers and the kids are not cooperating here. So we don't have a proper time or scope to just have a thing, but we do have it. But sometimes when it permits, definitely we do examine. But tympanogram, definitely that have some role whenever it is a chronic suppurative otitis media. We are persistent otitis media, we do go for it.
So we did have a survey conducted by CORE earlier, and we did find that some amount of importance of otoscopy was lacking and the skills were lacking. So Indian Academy of Pediatrics and our organization, we did do Autoscopy Workshops for pediatricians during the IAP respiratory chapter. We actually have conducted almost 23 such workshops a couple of years back. And I think that's very important. There's no reason why a pediatrician cannot, interpret the science. But of course, the exposure in their training program is not as much in this area. So we thought we'll supplement it, and all in good faith, not that we know more than the pediatricians, but just to share our knowledge.
Can I add a point?
Please.
Yes, Vidya.
Yes, sir. Apart from this pneumatic otoscopy, we also do nowadays for patients with chronic otitis media with diffusion an autoendoscopy and also a diagnostic nasal endoscopy, by which we also can identify the reason for the chronic otitis media with diffusion, like an adenoid tissue or a nasal problem, that can also be simultaneously addressed just without just giving the management towards only the otitis media with diffusion for the year.
Yeah,
good point, Vidya. Yeah. Dr. Lamberti?
The same thing.
Okay.
So we are talking about pneumatic otoscopy, and theoretically pneumatic otoscopy is definitely more useful in clinching the diagnosis. Truly speaking, we ENT doctors, we don't use pneumatic otoscopy nowadays, because we use autoendoscopy in all cases to see and examine the ear, nose, throat, everything. Autoendoscopy is a single tool in which is going to, if you use a smaller 3 mm otoscope or autoendoscope for the pediatric cases and 4 mm for the adults, which is more than enough to diagnose the findings in the tympanic membrane and in the middle ear. So clinically, I don't use pneumatic otoscope in all the cases. I use only autoendoscopy. And as we are told, we can use the same endoscope in the nose also to find out the cause for the acute otitis media.
Very, very valid points. And the other thing is, of course, tympanography grams are available also much more freely now than in, say, 5 years back or 6 years back. And it's a very good tool, especially done serially. You have fluid this month, next month, whether after 4 weeks, whether the fluid is going down or not. We'll come to that part. Because what we must remember is that even in acute otitis media, it's normal for the fluid to remain there for as long as 90 days. That is 3 months. So the problem is that many of us who are not aware of this condition give another round of antibiotic where it may not be required. So that's another place where we can restrict the use of antibiotic. So tympanogram gives us the additional benefit of serial monitoring to see whether the fluid is going down or not. That is another issue. Okay, go to the next slide, please. And so chronic otitis media with effusion, how will you treat this condition? So again, we go to all the ENT surgeons here. So we can start with Dr. Lamberti, of course.
Yeah. So the otitis media with effusion, whether it is a initial stage or in the chronic stage, we have to remember that it is a non-infective sterile fluid in the middle ear. So there is no use of antibiotics in the chronic otitis media with effusion. So you can treat the patients with nasal steroidal sprays to relieve the nasopharyngeal side of the eustachian tubal obstruction, or you can use nasal decongestants, or you can use antihistamines when there is an associated allergic rhinitis. And you have to wait, watchful waiting has to be done in chronic otitis media. Most of the cases, otitis media with the effusion will resolve in about 6 to 8 weeks course if you serially follow the case with the tympanograms or with your otoscopic examination. You can find out initially, you will see the air bubbles at the fluid level, which is completely reducing, and clinically also, symptomatically also, patient will be improving. So my way of treatment is you have to observe, treat the patient with the nasal steroid sprays and nasal decongestants, and if, in addition to that, if necessary, with antihistamines and allergic patients, not with antibiotics. But if it is resolving, then only I will go for the myringotomy with the ventilation tube insertion later, at least after 2 months.
Yeah, many a times in pediatric population, without any sign symptoms, it's only we find that the tympanometry is suggestive of a type B tympanogram, and a child might not be having any kind of symptom. Just wait and watch of at least 2 to 3 months, and we can doing a tympanometry again can more or less might have either it is a self-resolving, or if it is persisting, then we have to go and identify what might be the cause of the fluid behind the ear, and then we can address that condition as well. But as of now, we generally don't give until the child is symptomatic, no medication, and just a wait and watchful period. If child is symptomatic for any nasal condition with obstructive sleep apnea or nasal or breathing, and with otitis media, we tend to give nasal decongestion and nasal steroidal sprays. But watchful watching up to 12 weeks is actually that we generally follow. If there is no other symptoms, no need of any other medication. If the patient is having nasal symptoms, we give medication for nasal symptoms.
So these points I have discussed. Hello.
I think one point that we have to see is look for the presence of adenoids, especially in pediatric age group. Yes. Address that also as needed.
Raman sir, you are muted, sir.
Okay. The next, what I want to ask is from Dr. Vijay Kumar regarding the role of antibiotics in chronic otitis media.
When the patients are not symptomatic with a high-grade fever, there is no suppurative effusion. We are not.
Yeah, there's no acute symptom at all. Just fluid behind the eardrum.
But anyway, we should have given early periods and the previous Otitis Media, we should have given 2 or 3 courses of antibiotic, but not when we consider as a chronic, definitely.
So you don't think there's any role on?
It's not going to work anyway when the patients are not symptomatic with the fever or they don't have any major symptoms. As ENT surgeon said, the nasal sprays, decongestions, antihistamines may play a role more than anything. And other thing, the surgical considerations by the ENT surgeons may be helpful when we label them as chronic Otitis Media.
Neha, are you there?
May I
Can you hear me?
Yeah, I can.
Yeah, Neha.
Yes, so I again.
My question, there, especially in the pediatric practice,
yes,
people do advert.
Sir, your voice is breaking.
So
We are there. Pardon? Okay. Can you hear me now?
Yeah.
Some PCR studies did show presence of bacteria. Then later studies said that the presence of bacteria in the effusion doesn't mean that the bacteria is alive.
So, sir,
do you
important distinction that we always have to make, no matter which infection we are treating, that is to distinguish between colonizers and the true infection. So, anybody who has had a ASOM and then has gone forward and developed a CSOM, I will not say much about this. They will have some bacteria residing inside, and such bacteria may grow if you send a swab, or if you send some fluid or a superficial swab without a pus. So that will cultivate and you will get a PCR positive report. So we have to very importantly and clinically distinguish between the signs and symptom of any active infection or not. So it is when you guys are doing a scopy and whichever way of scopy you guys are choosing to do.
Right.
I think if you find any active infective material there, or any active signs of infection, not only fluid and pus is there, then only we should treat.
Sir, can I add a point also?
Yeah, by definition, chronic otitis media doesn't have any of those other clinical features. So obviously, role of antibiotics is almost a no-no. Vidya, quickly.
Yeah, 2 more things that I want to add is the role of the reflex. So there are studies that shows that the reflex can also cause aggravate the chronic otitis media with diffusion. So there is a slight role of lansoprazole for this. And the other thing is the role of the mucolytics, like carbocystin. There is a research on the role of carbocystin. So there have been studies saying that carbocystin also helps in chronic otitis media with the effusions.
As per many meta-analysis, there's evidence is very poor on as far as the mucolytics is concerned. So we'll have to keep that in mind. But having said that,
carbocystin, yes, sir.
But having said that, we are treating the patient, so we have to give relief. So you can transgress as long as the relief that you're trying to give does not have major side effects. I agree with you on that particular point. Next. Of course, antihistaminics, there are pluses and minuses. All of us know about it. So I think we'll go to the next, unless there is an active allergy going on at that time. So what are the general guidelines for management? Presence of middle ear effusion for 2 to 3 months after acute otitis media is natural. Do not prescribe antimicrobials unless patient develops recurrent symptoms. Prophylactic antibiotic for recurrent otitis media should be the exception than the rule. Consider myringotomy stroke grome plus minus adenoidectomy to prevent drug resistance. And ensure correct diagnosis of AOM to prevent unnecessary treatment, ensure patient compliance. This is what we've been discussing all through. This is just a summary of what we talked about. Now, I want to know Neha's opinion on long-term prophylactic antibiotics in recurrent otitis media. Just go back to the old slide. Prophylactic antibiotic has its own problems. What do you say? A lot of pediatricians use it. I know that.
So
Neha?
I don't think there is enough evidence to support that. Although, if we are having a recurrent infection secondary to staph staphylococcus, which is a problematic bug, or pseudomonas, then we can choose to treat it longer. But I think prophylactic antibiotics, we need to have enough data, which I think is lacking at the time being. And in such cases, it is even better to know the bug and then treat it. If we are kind of having such problem, because a lot of time in adults, at least, I see that patient is getting some amount of antibiotics on OPD basis, or we don't know the bug, some broad spectrum linezolids or broad spectrum levofloxacins are being used considering pseudomonas or considering staph, and then later on we find out that levoflox has happily given a porin and it is multi-drug resistant bug we are dealing towards the end. It may even extend to develop a skull-based osteomyelitis, a lateral one, or it may develop mastoiditis. Things like that can happen, extension can happen if we are not knowing and treating in blind. So if we choose, for whatever reason, we choose to use a prophylactic antibiotic, number one, there is less data, so we be very careful in wherein to use it. Number two, we need to be very sure about the bug that we are going to, prophylax the person against.
Got it. Yeah. Now, one quick question again to both the macrolides. You say macrolides increase resistance to Streptococcus pneumoniae, so use it very limited way. Having said that, macrolides are intracellular, their concentration is much more, and the three bugs which cause acute otitis media are extracellular bugs. So there has been a study on that saying that macrolides are not the appropriate choice for acute otitis media for this reason. What is your comment on that?
No disagreement, sir. I think you can still use it for agents or areas where you are, suspecting strep pneumo, or which is not in the area which is not where it is not very prevalent to have resistance, too much resistance. But in other places, I don't think it is very good choice for treating otitis media at first. So I think it is a bad drug to treat that, because most of the organisms, everything that we are dealing with, are not actually going to respond to that particular drug. So
okay. I think the resistance is much more in Southern Europe and Spain, where they use much more of the macrolides, I think. Yeah, next slide.
I think we use more than anybody else, any other country. Is it from
we use all the drugs more than anybody else.
More than anybody else. So I think we are just not documenting it. People don't know.
True. True. So this is for all the ENT surgeons here. When will you consider tympanostomy tube placement? Already, part of it has been answered. So, Ilam Bharati?
Yeah. So when the clinical diagnosis and an otoscopic diagnosis of acute otitis media is made, so I do confirm it with the tympanometry, and if it shows a B-type graph, and if the patient is having a long-standing acute otitis, that is otitis media with effusion for more than 2 to 3 months, then I will go for myringotomy with ventilation tube insertion.
Got it. Next, Vidya.
I agree with what Dr. Ilambarki sir said, but there is a slight change in the use of the tympanostomy tubes, sir. One is like, I don't use tympanostomy tubes in all the patients, because when there is like a serous otitis media, or the otitis media with diffusion with the serous fluid in it, I only do a myringotomy and I try to address the causative factor if it is there. But if it is thick mucoid or if it is multiple loculated, then definitely I would consider usage of myringotomy tubes, sir.
Good point. Dr. Naik, quick response.
Yes, sir. No, sir, at least 3 months of trial or watchful period can be given. Later on, then if it's not subsiding, then we can go over to the tympanostomy tube and address the underlying condition.
Do you also feel that if the fluid is thin, you need not use the tympanostomy tube and use it only when it's thick, or you will put it anyway?
I would put it anyway, sir.
See, so there are situations where you need to, customize the treatment for that particular patient.
To add to that slide, hello. The ventilation tube, that word itself, it is only ventilating the middle ear. Whether it is a transudate or an exudate, whether it is a thin secretion or thick secretion, it is better to put the ventilation tube in otitis media with effusion. That is my point.
Thank you, sir. Okay. So we find out what's the international guidelines. Bilateral OME present 3 months with documented hearing loss. Unilateral or bilateral more than 3 months with symptoms including ear discomfort, vestibular problems, behavioral issues, as well as decreased quality of life measures. Acute otitis media and unilateral or bilateral MEE at the time of evaluation. recurrent otitis media. And at-risk children with OME that is thought to have a low probability of resolving spontaneously. I think most of these points, all of us agree? Yes.
Yes, sir.
Yes, sir.
This is what we
Okay,
follow.
we go to the next slide. Yeah. Okay, we did a study here. Of course, I'm not going to discuss what exactly was otitis media with effusion in urban pediatric population in a tertiary care center. At one time, we used to do almost 200 and 250 tube insertions in a year. I mean, you'll be surprised. We used to follow all the guidelines. So there are so many children. If you have an interaction with a very enlightened pediatric population, pediatricians around you, like I'm privileged to have, we have referrals for the right time, and then you keep following them. And we are in a place where the literacy affordability is much higher. So we did have large numbers, and we've analyzed those results. Next slide. How will you treat recurrent otitis media is the next question. Again, it's part of, let's put the slide for sake of time and then discuss. So in case of recurrent otitis media, if the child does not have middle ear effusion, then tympanostomy tube should not be performed except when the children have severe or persistent AOM, presence of immunosuppression, presence of complications of AOM, mastoiditis, meningitis, facial nerve palsy, and children with allergy or intolerance to antibiotics. So this is recurrent otitis media. But some of the mentioned sections in one year, you're justified doing myringotomy and grome. What is your take on this? Pratik?
Sir, your voice is breaking, sir.
Yeah. Okay, Dr. Nayak, earlier guides mentioned that if a child has got 3 infections in 6 months or 4 infections, acute infections in a year, then you're justified in doing a myringotomy and grome. But this particular recommendation is different. So what is your take on this?
Sir, I had a particular patient who presented with the recurrent otitis media, and all the 3 times, second times, 2 times he presented with a facial palsy, and then the third sitting we had to give a gromate insertion. If the child is having recurrent acute otitis media, first of all, before putting the gromate, the underlying condition is definitely to be addressed. Is it the adenoids and a nasal allergy or any other pathology? Simultaneously, we should, if we are addressing that pathology as well, we should simultaneously go ahead with a tympanostomy tube insertion as well.
So there is an audience question here. Maybe Dr. Vidya, can you answer this? That is, how do you prevent
Hello, your voice is breaking.
Sir, your voice is breaking.
Yeah. You prevent blockage of the tympanostomy tube?
Yeah. So one way is to use if it is a kind of a grown-up child, we can actually examine and we can advise drops, ear drops. Hello, am I audible?
We are hearing.
Yes, you're audible.
Yeah, you can even use sometimes we can even use the oxymetazoline or xylometazoline drops also. That can also cause some, first you try with the saline, or then you can even use the oxymetazoline or xylometazoline drops transiently for maybe 2 or 3 days. And if it is thick crusting or thick exudate that has already sealed, then I usually try to remove it with the suction in my OPD itself, and I remove that blockade and make sure. Then I also irrigate with saline and do some suctioning, and then make sure the patency of the tube is achieved. If it is blocked completely, and if there is some amount of space surrounding the tympanostomy tube, and still if the ventilation is maintained, then also we don't generally not disturb it. But if there is no space around it, and if the tube is completely blocked, then we have to intervene it.
Thank you. Next slide, please. Now we come to the role for adenoidectomy in the treatment of otitis media. I think some of you have made yourself clear on that point. Now, what is anything you want to add in addition?
No, definitely,
Yeah.
adenoidectomy is indicated in the pediatric age group if it is there causing the obstruction in the nasopharynx and if it is the cause for the Eustachian tubal block. So one of the basic pathogenesis in acute otitis media, if the effusion is the Eustachian tubal dysfunction or obstruction. So if it is caused by adenoid, then it has to be operated.
What about you, Vidya? You agree?
Yes, sir. Exactly, sir. Being a pediatric OSS surgeon, I totally agree to what he is saying. But apart from what he says, it's not the size just matters, but even the presence of adenoids or tubal tonsils, even if it is there, we need to address that also. So just don't go with just the size criteria, but also look at the obstruction caused by even a grade 2 adenoid. If it is obstructing the Eustachian tube, you have to address it.
Yeah.
And
Okay, good.
yes, sir. Thank you, sir.
Yeah,
Obviously, I follow this age criteria also, but definitely if it is very severe, even if the child is under the age of 4, we will definitely, there has been instances where we have treated if it is not responding to your medical management, and we have to, if the child is having hearing loss and otitis media with effusion. Yeah.
So the current guidelines say under age 4, when Grome is recommended, you do not have to do an adenoidectomy unless clear indication exists, which means you do it only if it is the adenoid itself justifies removal. Don't do it. And more than 4 years, adenoidectomy is considered along with Grome, whether it is obstructing or not obstructing. So that is where the adenoid may be an area where there may be a colonization with bacteria. Can you hear me?
Yeah, we are hearing you, sir. Yeah.
Hello?
Yeah, we are hearing you.
You can hear me.
Yeah.
Okay.
Yeah. You are audible. Yes, sir.
1 minute. 1 minute.
Oh,
Hello, Dr. Raman.
I think it got disconnected.
yeah.
So there are a couple of questions, and that is, what is the tympanostomy tube of choice when we do menigotomy?
It depends upon the ENT surgeon's preference, I think. So one is the, you have got, there are many types of tympanostomy tubes, either single flanged, double flanged. So one side of flange, you can hold it with the forceps. Other side, the flange, you can introduce inside.
So it's purely ENT surgeon's choice.
Yeah, it is choice. So single flanged or double flanged, or you can go for the, this is a T Perlis T tube, depending upon the availability and also your choice.
Is there any role of oral steroids, sir, when we suspect? Oral steroid.
Oral steroids for otitis media with effusion.
Yes.
But the evidence-based studies shows that there is no clear-cut role in treating with oral steroids, but we do treat most of the patients for a short tapering dose of oral steroids for about 2 weeks, whatever the benefit the patient is getting. But we give a tapering dose of oral steroids for at least about 1 to 2 weeks till the waiting period of patient is going for meringotomy with the ventilation tube.
Dr.
So it has to be used occasionally.
Yeah.
Can you hear me?
Yeah, we are hearing you, sir.
Yeah. Sorry, I think again lost connection. So we've come to the next slide. Let me go back to and talk about adenoidectomy itself. See, the British
slide only is there.
earlier, but the British recommendation earlier had said we are not talking about adenoids which are enlarged causing symptoms. They have to be removed. But if you're going to take care of the doing a tympanostomy tube for chronic otitis media with effusion, then do you do an adenoidectomy at the same time? At that particular time, they had said you do not do an adenoidectomy, but do an adenoidectomy only if the child requires reinsertion of tubes. Now that guideline has been changed according to ICON, that is the International Consensus on Otitis Media Treatment, and the American IAOHNS guidelines. This is the latest one which is shown on this particular slide. Yeah. But I guess you have to use your clinical judgment and do it. As far as
yes, sir, we have to take both adenoids and otitis media as a we have to address both the condition. We cannot keep them separately and treat them separately. I feel we as ENT surgeons, we tend to address adenoids as well as we simultaneously look for the tympanic membrane and whether the resolution of the otitis media is happening with the adenoid treatment with medical management.
So there's no confusion when the endlines are enlarged. The point is when the adenoids are not enlarged, the theory of removing it is basically for this.
Yes, sir.
Next slide. Yeah. So these are all, I think it's a very busy slide. Summarizes what we have talked about up till now. And we came out with our first consensus, I told you, in 2002. And this is included in the website of IAOHNS for better, this is just a summary of what we have talked about. I don't want to waste time. On persistent otitis media, recurrent otitis media, everything is given here. In fact, I had asked the enlightened panel to go through that. And if you think anything has changed since 2002, we'll be happy to incorporate it. Now, in conclusion, one of the most prevalent diseases in childhood is otitis media. We need to treat it optimally. It is a spectrum of conditions because many times we confuse, even amongst ENT, when you're talking about acute otitis media, somebody is talking about chronic otitis media, and various panels and discussions. I've seen people talk at cross purposes. So we need to know what we are talking about. There are different management strategies for each one of these, and sometimes different opinions, whether to remove adenoids, not to remove the adenoids, whether to give a course of steroid, etc. Avoid imprecise diagnosis, avoid inappropriate and inadequate treatment. And the goal is to optimize treatment for better outcomes and avoid increase of antibiotic resistance. That is very, very important. And the very idea that Neha is here today is just to act as third umpire on us so that we don't go around flashing our antibiotics for every case that we see. And any concluding remarks from our panelists? I mean, it's a full house, you can say. And meanwhile, Vijay, we have questions which we have not answered. We can just do that if time is there.
Raman sir, this is the first slide you have put, the same slide. You have put it as
yes, exactly. Because, medicine is repetition, as you know. And some of us take it very literally and appear for the same exam again and again. I'm not talking about that. So this is to reiterate and take home messages. That is the aim of today's discussion. Otherwise, why waste IAOHNS time, GSK time, and our time on talking about something so trivial as otitis media? Any questions, Vijay?
No, sir. There are a couple of questions. I will post it individually, sir.
Okay, wonderful. Extremely sorry for the computer business, but I felt good when your computer also hung.
I think the presentation was a little heavy. That's fine, sir. The topic is
right.
Thank you, sir. It's a wonderful experience.
It's an absolute pleasure.
Thanks, all of you.
It is so nice to learn
Dr. Vijay Kumar, you're the cross-border terrorists. Welcome. Thank you very much.
We have come across a lot of insight about otitis media anyway. And just we want to just use the scope and we try to just use it. One of the restricting factors is wax, and we do have difficult to control the patient anxiety and to control the babies to just do an autoscopic examination. But wherever it permits that to help, definitely we do it.
Very true. Very true. Neha, any comments? Concluding comments?
No, sir. Thank you for having me here. It was really enlightening session. Just a repetition of what I already said. Always right dose, right drug, and right duration, and maybe avoid
wonderful
antibiotics. That will be the last message I would put up.
Wonderful. Shall we leave it now to Vijay to give us concluding remarks?
Yes, sir. Thank you so much. On behalf of Indian Academy, I would like to place my sincere thanks to this entire faculty who has joined for this live webinar discussion on this Sunday evening, sparing their time from their family for teaching and sharing your knowledge with us. And I also would like to thank the participants who are nearly 800 across India, who are really encouraging us to conduct more program, and our moderator, Dr. E.V. Raman sir, today from Bangalore, who has a vast experience in this field, has clearly got the most possible and practical messages on this topic of rational management of acute otitis media from all the faculty, who are key opinion leaders in this field. And I would also like to place my sincere thanks to Dr. Neha Mishra, who is a consultant infectious disease specialist, who immediately accepted our invitation for participating on this day, on this Sunday, to share her tremendous experience on this topic on viral flu and COVID in this situation. And also I would like to thank Dr. Deepa, who came in suddenly in timely help to Dr. Raman for sharing the presentation from her laptop. And I would also like to thank GSK, especially Mr. Sundaram, Shankar, Kaushal, and their team who are working behind this program to help spreading the knowledge, which is the main aim of Indian Academy. Those who are not members of IAOHNS, I would like to welcome to be a part of IAOHNS. Be a member of IAOHNS. You can download the membership from our website, iaohns.com, and visit our website for the update on the next webinar on different interesting topic with the interdisciplinary team. I would also like to welcome you all to Nagpur for our national conference of IAOHNS, which is going to be the last week of November 25, 26, and 27. Welcome you all. So we have a huge list of faculty with interesting topics, lectures, live surgeries, pre-conference hands-on training workshops, instructional courses, debates, etc. Visit iaohns2022.com and come into Nagpur and enjoy the tiger capital of the world. Thank you. Thank you all.
Thank you very much for inviting us for participate in this. And Deepa, thank you very much too.
Thank you all.
Thank you. Thank you, Vidya. Thank you,
everyone.
Thank you.
Thank you all. Very nice to see you.
Thank you.
Are we off air now?
Recording stopped.
Yes.
Okay.
Yes. Yeah.
Thank you so much, Gautam. I mean, and all of you. Yeah, participants were very, very, reactive, and I hope we sent the right message.
Yes, sir.
Thank you, sir.
Absolute pleasure, sir.
Excellent moderation.
Thank you. Hoping to see you in person.
Yeah. Thank you. Thank you.
Sure.
Sure, sir.
Bye.
Good night. Good night.
Good night.